And I think that's it from me, Chair. Thank you. Obviously, governance of funds and roles are important for me. Thank you.
Honorable Singwa.
Thank you, Chairperson. Let me welcome the presentation and greet all the members and say Happy New Year. Chairperson, am I audible and can you hear me?
You are very honorable, Ms. Lingwa. Let me just remind honorable members also that this is a live broadcast on YouTube, Twitter, Facebook. It's also delayed broadcast on Parliament TV and also being published on IONO. So thank you, Ms. Lingwa. You understood what I was asking for. Thank you.
Thank you. To the Bonitas, I have 3 questions or seeking clarity questions. First of all, has there been any interaction or discussion with the Department of Education on the interpretation of what services would be considered or complementary services not covered by private medical aid scheme? What in your view would such services entail, and do you think this fact they are constitutionally concerned with this provision? Secondly, what your interpretation of these referral pathways and whether it will be technical means a person on a medical aid scheme can choose by not opting for the referral pathway to assess a healthcare practitioner whose services would be covered by medical scheme. One can also ask whether this has been any consultation with Department of Health on this aspect. The last one, there is a submission by the Professional Councils of South Africa on the 18th May 2021. In that submission, it was held that it must be clear that NHI takes over from medical scheme must be transferred to NHI. These viewpoints have raised serious concern with the medical schemes and legality of proposal is highly questionable. It will be interesting to hear from you or from here for your viewpoints on this opinion made by the council in their submission. I thank you.
Honorable Munya. Honorable Munya, you're next.
Thank you very much, Honorable Chair. I think I had a problem with this some network. My apology for that, I must say. Honorable Chair, I must say that the presentation by Bonitas is noted, but they are concerned that not all healthcare providers will be contracted to NHI fund. It's noted. Are they aware that the white paper and the bill states that contracting with private providers will be undertaken to improve access to healthcare services to all South Africans, as well as to reduce the burden of disease? That is my first question. Are they aware, this is carrying on now, are they aware that Section 37, Section 39, Section 41 of the bill, I think it's imperative they look at that if they're not aware, because these matters are greatly clarified in those sections that I've mentioned. You have argued, I think from the Bonitas point of view, that all international concepts of universal healthcare make provisions for freedom of choice. Is this statement based on evidence? I mean, scientific evidence. Some of your stakeholders in the industry have argued that there are different types of universal health coverage models. Some like us in South Africa, they believe that NHI is a model for universal health coverage, while others are different in respective countries. Honorable Chair, allow me to also ask another question. I'm trying to scribble with my notes here, Honorable Chair. The other question that I have, ideally, yes, there should be a stronger and better collaboration between the healthcare facilities, regardless of the sector from where they are located, from which they are. Another, in the slide 4, for instance, there appears to be focus on the volume of distribution of users between the current public and private sectors. What is more important is to bring attention that there's a lack of equitable distribution in terms of cost of provision of healthcare in both the public and private sectors. The lack for equitable access of healthcare is what provision of the bill is addressing. My question, therefore, is, Honorable Chair, is there any reason why, as for Bonitas to advocate for the private healthcare sector so much, given the challenges we already know that they exist in the sector, particularly regarding the high cost of healthcare in the private sectors? Maybe finally, 8% accounting for 400 billion rand of the healthcare facilities healthcare money goes to private sectors, and yet the majorities of our public infrastructure don't access that money. That is the consequences why there's uneven including of infrastructure in the public sectors. Exactly, we want to address the status quo of the two-tier systems. Are they comfortable with the status quo of the racial two-tier system that has been there? If they can address me on that question. Thank you.
Chairperson, thank you very much for the opportunity. I would like to ask the following questions to the presenter of Bonitas. You say that you support the concept of universal health care, and under your key consideration, you raise the importance of the flow of funds to the service provider. Do you not feel that the bill will ensure remuneration to service providers? And secondly, are you comfortable that the bill adequately addresses who will be a qualified or accredited provider, especially as outlined by the role of the Office of the Health Standards Compliance? Secondly, you are also concerned that the bill ignores other legislation. Could you please share with us which are of your concern? And you raise that the bill places restrictions on the rights of healthcare providers. Please help us understand which rights you are referring to, especially as the requirement of the Office of the Health Standards Compliance will ensure quality of service provision. Lastly, is it not your understanding that the bill sets the framework, not details around the management of funds, financial planning, or budgets? Those details are to be set out in the regulation and operational plans of the NHI fund. Then why does Bonitas think this should be outlined in the bill itself? Thank you, Chair.
Good morning, and thank you for the presentation. Chair, I just have a few questions. My first question, what recommendations can you provide to improve the accountability and legitimacy of the board? Should the private sector be included on the board? My second question, how do you feel a balance can be found to find workable and sustainable solutions, especially due to the lessons learned from COVID? My third question, in your opinion, how well does the bill protect the fund against corruption, theft, or maladministration? Do you think processes have been adequately put in place to check corruption? Would you recommend that the department does a pilot study to test legal and operational feasibility? How important do you feel a pilot study is for the success of a project? Is it something that can be bypassed? Would you support the NHI in its present form? Do you feel the NHI in its present form infringes on the rights of healthcare? And what is your view on the impact of a single purchaser model? Now you mentioned, it's mentioned that the funding model is unclear and therefore the sustainability of the NHI is also unclear. Now, assuming that there is not enough funding a few years into the implementation of the NHI, how can this impact access to quality healthcare or even the economy? Thank you.
Honorable Clark.
Thank you, Chairperson. Thank you for the presentation. I have been covered in some retrospect in terms of the questions, but I would like to ask the following. NHI is intent to create a more inclusive health system. Is your presentation, you mentioned that it will actually result to barriers of access. What would you say the biggest barriers of healthcare access via this bill are? What impact will NHI have on the quality of healthcare services? In your opinion, how strong is the current structure of the bill in preventing looting and management of funds? And my former member, Ismail, mentioned that. Could you please tell us how would you identify the weaknesses in this regard? In your opinion, can South Africa afford and sustainable such as NHI, considering the current economic climate? The presentation mentions that the government structures lacks accountability within the bill. What recommendations can you provide to ensure or improve the accountability mechanisms within the bill? And then in terms of liabilities, in terms of the bill and the legal aspects that could be challenged in a court of law in terms of not aligning to the right, to certain rights within the bill. I mean, how would you as a scheme elaborate in terms of those rights? Thank you.
Thank you, honorable members. I am now the last one to ask any questions. Let's also be mindful that you have until 10:14 to complete your answers. I know there are so many questions raised to you, Mr. Polmed. But mine is based on 4 points. One is on complementary cover. Secondly, on milestone approach that you raised. And you also raised restriction to healthcare and non-contracted healthcare providers. So on the first one, you have a concern that medical insurance schemes are excluded in the bill. Now, I would like to ask your view on the following sections, which are sections 1 and section 55, where the bill defines complementary cover to mean third-party payment for personal health care service benefits not reimbursed by the fund, including any top-up cover offered by medical schemes registered in terms of the Medical Schemes Act or any other voluntary private health insurance fund. Question I want to ask you on that section is whether this does not cover medical insurance, and also in terms of the complementary cover, what is your opinion on duplicative cover? And here I mean funding from the NHI, medical schemes, or any other health insurance providers for the same health services. Will that not perpetuate the current inequities, thereby threaten the achievement of universal health coverage? Remember that human resources for health in South Africa is also biased towards the private sector, and this is annually demonstrated through publication of density ratios by catchment areas. And then on the milestone approach, I'd like to know what your definition of that milestone approach is, and what are the milestones that you at Bonitas have identified, and how does Bonitas suggest that it should be included in the bill, and under which section of the bill? And then my next question is just a little moment. With regards to your assertion on section 2 of the bill, and I was thinking you probably meant chapter 2, that there is restriction that is placed on access to healthcare on those with the means to pay. And I'd hope that you'll be able to allude or show where this is actually captured within the bill. And can you provide wording that you would like to see used in the bill related to non-contracted healthcare providers, and explain your concern about the role that you wish for them to play? I would want to just raise another one on section 7, subsection 1, and section 21, subsection 1 of the bill, which makes provision for the constitution of the Benefits Pricing Committee. And it also makes provision for a Benefits Advisory Committee. And what is your view on those committees, and whether those committees would not be able to address some of the data issues which you have raised in the presentation? Before I allow you an opportunity to answer these questions, Mr. Polmed, I see that the hand of Honorable Munya is raised on the platform. Honorable Munya.
It's just one. It's just one follow-up. I won't take your time, Honorable.
If it's a follow-up, if it's a new question, please go ahead. Thank you.
If you look at your right, the gap.
We cannot hear you, Honorable Munya. We have seemed to have lost you, Honorable Munya. I will hand over to Mr. Polmed to answer any of the questions.
I'm here, Chair. I'm here.
Thank you.
I'm here, Chair.
Yes, you're welcome.
I want to ask, because the presenter says that there's some areas of the bill that could be legal. I'm asking the question explicitly. Number one, is it illegal? Is it illegal for Section 27 of the Constitution to provide open quote? Everyone has the right to have access to healthcare services. That state that must be reasonable, legislative, and other measures within its available resource to achieve progressive realization of each of these rights. Is it illegal as per Constitution for right of healthcare, right to life? Is it illegal, Honorable Chair, for Section 2A, for Constitution that state that reasonable, I think what we're doing now, the bill tried to put a reasonable legislation to really measure within its available resource to achieve the progressive realization of the right to access of healthcare services for all our people. Is it illegal? I'm sure Bonitas will clarify.
Mr. Kolakopa, thank you, Honorable Munyai. You have until 20 minutes too, but considering the number of questions, I might just give you another 5 minutes or so. Thank you. You're very welcome to respond.
Honorable Chair, thank you very much, and thank you for the members posing these questions to us. I must say it's challenged my note-taking skills. So please forgive me if I don't cover all of them, but I've asked some of my team members also to cover some of the, or take some of the notes. So with your permission, Chair, if we don't adequately address all the questions, we are more than pleased to make, along with our original submission, some amendments to address some of these questions, if that pleases you.
Yes, you're welcome.
Thank
and
you.
whatever you cannot answer, you can also give us written replies, but do your best to answer these questions.
Most definitely, Chair. Chair, I would like to start with Honorable Munyai's point, and I think it's a very critical and principle-related point that he makes, or that he poses to us, is that are we saying that it's illegal? First of all, Honorable Munyai, for the purpose of answering the question, we support universal healthcare. We are not saying that it is legal in terms of what is intended through the bill. What we are trying to highlight in enabling and progressing the bill further is that based on some of the aspects that we have highlighted, it may be construed or challenged and be perceived as that it's illegal. But it is not the intent to say that the bill is illegal. It's saying that how can we, through the processes that you have afforded us, able to highlight some of these aspects that needs refinement to prevent any stalling or challenges from a legal perspective. So to answer your question, no, it is not illegal to drive the intent of giving people access to healthcare, and that is Bonitas' position on that particular point. Chair, starting then in the order on which questions was raised, starting off with the point around what has been our rate of growth over the last 2 years, the impact on turnover or member turnover, and which months do we see traditionally our growths, as well as disputes being raised or being reported for the scheme to CMS. I'm going to start with the first question, and I'll allow my CFO to just answer one or two of the other ones. First of all, in terms of which months do we traditionally see growth in terms of membership, that normally happens in the first month of a calendar year, being January. The reason for that, Honourable Member, is that this is when benefits change and where members are afforded the opportunity to select an alternative. So traditionally, pre-COVID, this is the month of January is where we've seen those changes and where the scheme would traditionally see the maximum growth in terms of membership, if any, or even a reduction of membership. During the course of the year, you would have also turnover and growth, but to a lesser extent to what you would see in that first month of the year. With COVID coming in and also the appeal from CMS to address contribution increases, our operating model has changed significantly in terms of where you have seen other medical schemes suspending their increases to later in the year, etc. So the traditional model of where you've seen membership growth in January, where the vast majority of growth would have been seen, we anticipate that that will change during the course of this year and the years ahead, should that model continue to take place. In terms of the number of disputes from a Bonitas perspective, we will draw from the Council of Medical Schemes report those numbers and provide that to you in writing. Luke, can I ask you to comment on the Honourable Member's question in terms of membership growth for the last 2 years, please?
No problem. I can give those figures. I'll go back a few years because I think the Honourable Member asked for 4 to 5 years. From 2017 to 2018, Bonitas's principal membership decreased by 2.3%. From 2018 to 2019, it increased by 1.7%. From 2019 to 2020, it reduced again by 1%. And then from 2020 to 2021, it increased by 2.1%. Obviously, the decrease in 2020, was a symptom of lockdown regulations imposed with employer groups shutting down and a contraction in the economy that certainly impacted the Bonitas membership in 2020. I think we generally budget and forecast for between 1 and 2% of growth from year to year. However, it must be noted that the private sector, private healthcare market is extremely competitive environment with very little growth, on a consolidated level across all medical schemes, particularly in a very challenging economy. That pool of members that qualify for private healthcare very much remains the same. So what you ultimately end up is a lot of churn across different medical schemes with very small growth factors in place on a consolidated level. Thank you, Lee.
Thank you very much, Luke. Chair, one of the other questions that was posed to us is in relation to complementary cover, and specifically, what do we, first of all, and I would allow Dr. Morgan Makwacha just to highlight a key element around what was being asked in terms of what do we anticipate or foresee the complementary or the cover should be. But the question that was asked specifically was, what do we see that primary cover, that baseline package, what should it be? And to that point, in itself, in answering this question, that is the challenge for us, not knowing what the benefit package would be that is intended as a baseline for NHI, but further to that, where the funding would enable it. And I think Honorable Wilson made the point that the question has been asked by multiple presenters in terms of what would the funding be, because funding would inform specifically what package or what benefits would be available. But we will answer this question based on what we perceive as potentially the starting point of NHI should be in terms of a baseline package. Dr. Morgan Makwacha, can I hand over to you?
Thank you very much, Chair, and thank you, Lee, for the opportunity. As far as we are concerned in terms of primary health care, our emphasis is on member education and making sure that our population or the citizens of this country adjust their lifestyles so that they minimize the diseases that are caused by lifestyle behavior. So really behavior education should be primary. And then with that, it will lead to early diagnosis of the diseases, which shall help in making sure that people are diagnosed at pre-disease level and are managed accordingly to try and reverse or arrest the progression to severe disease. In that way, then it will take off the load of the hospital system. And if then we diagnose them as already having the severe disease, this is how to educate them so that they manage their disease as effectively as possible. And in that way, make sure that they don't end up costing or overutilizing the resources that are available to the country. I will stop there, Lee, and if there's more expansion needed, I will then expand. Thanks.
Mr. Kopan, can I just interject very quickly? I see your team does not switch on the videos, and we are doing live broadcasts, if they don't mind. Thank you.
Noted, Chair. If I can ask just the team members to honor the request from the Chair, please. Can I continue, Chair?
Yes, thank you.
Chair, there was also a number of questions asked from the honorable committee members in terms of corporate governance. And starting off in terms of, you just allow me, just want to get Chair, the question was asked to us in terms of in our opinion, from a corporate governance perspective, what can be done differently. I think starting off with a key point that we have assessed from the bill is that the appointment, the minister should actually, there should be duality. So the minister should be appointing the board, and a board that is elected through a due process with independent oversight, as is the case with many boards being selected through a bill of this nature, that once the board has been selected, that the CEO is appointed and various governance structures is applied. But to give the minister overarching decision-making in terms of the appointment of the board, the CEO, etc., that in itself is some challenges. Our learnings from the Medical Schemes Act is probably an area that could be considered in amending specifically the bill to be able to cater for better corporate governance, but also in terms of putting the necessary controls in place in terms of reporting and oversight. The question was also posed to us in terms of should the public participate in that process, specifically the advisory committee. We believe the more transparency there is through following a due process of having public members or members from society and civil society to participate in the various structures, the better credibility it will give to the process, but it will also be able to contribute in terms of feeding into all decisions and actions being taken. There was a number of technical questions, and I think, Honorable Chair, linking it to your particular point in terms of certain sections, with your permission, would like to consider that at a more technical level to provide you with responses in relation to it and actually provide that in writing to you. Chair, just moving on to some of the questions that was posed by Honorable Slangwe. Apologies if I do not pronounce the name correct, but the first question that was asked was any interactions with the Department of Education, but I think it was meant to say Department of Health. To that point, we also, as Bonitas, belong to a association, which is the Board of Healthcare Funders, BHF, which I know has made representation to this committee. And through that forum and industry body, we continuously engage and make or put engagements forward to the National Department of Health, as well as our current regulator. But to answer the point explicitly, as Bonitas made direct engagement, no, we have not, Honorable Member. We took the part of engaging through these forums, but we trust that if those forums and engagements are made available to us, Bonitas will definitely make or play an active part in making those contributions. The other question that was also asked was in terms of referral pathways. Has there been consultation with the National Department of Health on the subject over the last number of years? Once again, allied to the point that I've made earlier, is that through our industry body and our forum, we make contributions, and that is advanced through the various national departments. But to answer the question also directly, not directly as Bonitas, but through our industry forums. Honorable Member, you also raised the question around the legality of what that was suggested by the Health Professional Council to transfer these assets into a central fund. To that point, we do not support that suggestion that was made, is that medical funds and the assets should be actually all drawn into one central fund. We believe that it would be irresponsible at this particular point in time until such time that specifically the good work that has been taking place through engagement and receiving input from various stakeholders, until such time that the bill has been clearly defined, benefit packages have been defined, funding has been defined, and we cannot go and make such statements. It would be irresponsible. The reason why I say it is irresponsible is that it leaves the mind of the ordinary South African citizen in a state of limbo and question around it. But not only that, it would also attract other challenges, such as groupings or societies or individuals challenging such actions that could actually just once again put the strain on other resources like our legal system. So, Honorable Slangwe, I trust that I was able to address all your questions. Moving on to Honorable Munye. Honorable Munye answered the question that you asked in terms of legality. You indicated that you know that not all providers, or you posed a question throughout the observation of what we've presented, that you noted that we said that not all providers will be contracted, and if are we aware in terms of how the bill is set? Most definitely, we are aware of it, Honorable Member. The only question that we pose is that in the current format is whether those providers, if going through the contracting process, whether they will be willing to contract, and whether would that imply and have other unintended consequences, such as providers exiting the healthcare system as a whole and leaving the country. Those are aspects that is unintended consequences that we need to anticipate and engage on. And that is the point we were trying to make, rather than just stating that they won't. It is not a view, it is just a risk analysis opinion that is being shared. I think this also pointed out some of the questions which I couldn't all record, but I think it was the ninth question that, or the eighth set of questions that was asked in terms of lessons learned and whether we should be piloting a system such as this. This is exactly what is meant also being suggested in terms of a milestone approach, is that the whole intent around how to operationalize universal healthcare, that we take a more prudent and responsible approach by piloting and taking certain aspects based on a framework. You'd recall my presentation spoke about a more formalized, well-integrated framework being developed, that those aspects be developed as part of also enabling the NHI bill to be able to move forward. So in answering the question around piloting, yes, it would probably be the more prudent and responsible approach to take. And to the point of Honorable Munye's question, I trust that that answered the question. The other point that was made around was freedom of choice. Is it based on evidence in terms of different models around the world? It's an observation of obviously the literature that we have considered, but it's not a definitive view in terms of saying that there's always a freedom of choice. Different systems and different models works obviously differently for the environments in which they have been crafted and developed. And that is our humble appeal in saying that, considering what has worked in terms of multiple models or different models in different countries, is that we also have to consider the uniqueness of Africa and South Africa in terms of developing and putting models forward that will best work for us. But we have to do it in a responsible manner, not depriving civil society in South Africa, South Africans, of the rights that you've articulated, Honorable Member. So the intent from us is not to challenge and to say that this will not work. Our humble appeal throughout all the questions and statements made, questions directed to us and statements made by us, is to say, can we take a more responsible, collaborative working model that will advance universal healthcare much faster and further to ensure that everybody has access to quality of care, to the point we believe by starting or by addressing the challenges in the private healthcare sector, which I think Honorable Wilson also highlighted. there's no doubt that there's cost challenges in terms of affordability for South Africans in private healthcare. And one would say, what is that cost in terms of, is it affordable or not? It's a relative point. But we know compared to other countries, and to the point of the numbers that was quoted, that 8% is responsible for 400 billion of healthcare costs. That is just too expensive. And what we're appealing for is that there needs to be some reforms implemented to bring the private healthcare costs down, to ensure that more people can have access to it, rather than being faced with the challenge of affordability. And the Health Market Inquiry made quite good recommendations in furthering that. And that will further enhance and move us in terms of equitability, in terms of healthcare for all South Africans. Chair, I'm just mindful of the time. We've got another 10 minutes or so. If you'd allow me to suggest to the broader committee that we respond to all the other questions, which is more technical of nature in writing, we would be very pleased to do so. Thank you, Chair.
Thank you very much, Mr. Kolakopen and your team, firstly for your presentation, and secondly for answering these questions. And we're looking forward to you writing to us on the questions you may have left out. Honorable members, we will go directly to the next presentation. And Mr. Kolakopen, you are very welcome to stay on, or you're welcome to leave as your team. And any last words from you on this particular presentation? You are muted, Mr. Kolakopen.
Chair, just a final word to thank you once again for allowing us to present and also allowing us to respond in writing to you on the questions. And we wish you well in terms of the good work that you're doing to further and achieve universal healthcare. And we hope that schemes such as ourselves and the private sector as at large can make a meaningful contribution to aid us to achieve this noble task that we set ourselves out as South Africans. Thank you.
Thank you very much. Honorable members, as I said, we're going directly to Discovery Health. I would hope that the leader of the team who will be representing Discovery Health on our platform, I see Mr. or Dr. Saluba has just switched on his camera. I would think that is probably the team leader then. You're very welcome to this portfolio committee meeting. You would probably maybe been listening to part of the what I had said this morning as to what this meeting is all about. And you know that you are here to present to us as a portfolio committee on the NHI bill, and that you will be making an oral submission in addition to your written submission that you had already made to the committee. So very welcome to this meeting this morning. You are welcome to also introduce your team, and we take it from there. Thank you very much.
Thank you very much, Dr. Jacobs, the chairperson of the portfolio committee. Also, just to recognize the other members of the committee who are here. Let me also recognize our Deputy Minister, Dr. Dlomo, and the senior colleagues from the Department of Health. Chairperson and honorable members, let me also join in wishing all the committee members good health and strength in this very important year. Let me, on behalf of Discovery Health, thank you for affording us this opportunity. We are conscious that some of the ground has been traversed in the course of these hearings in respect of the merits of the legislation before us, as well as the challenges and risks we need to collaboratively mitigate. We shall focus on what we believe will help enrich your deliberations as you grapple with this nationally important reform initiative. Let me therefore begin by introducing our delegation's honorable chair. In our delegation, we have Dr. Ryan Noach, who is the CEO of Discovery Health. We've got Professor Roseanne Harris, who is the head of Discovery Health's Health Policy Unit. And we've got Khalid Mayet, Head of Discovery Health Legal Unit. I should have also indicated that I'm Ayanda Nsaluba, a Group Executive Director in Discovery and Chair of the Management Board of Discovery Health. We will share the presentation and we'll try to do so as seamlessly as possible. After my brief input, I will invite Dr. Noach, who will step in, who will then be followed by Professor Harris, and all four of us, including Mr. Khalid Mayet, will then participate in responding to your questions. Honorable members, we firmly believe in the need to build an inclusive and resilient health system. If nothing else, the COVID-19 pandemic has demonstrated the importance of this, as well as the importance of partnerships in advancing this imperative. Discovery believes that to achieve this, we need to confront the challenges facing both the private and the public sectors, and therefore are in support of structural reform in the health sector. We fully support the principle of integrated national health system reform for public benefit. We're entirely in support of the aspiration of the NHI bill, which encompasses broader access to equitable healthcare for all South Africans. We see some risks in the technical design of the system, which may inadvertently adversely affect the achievement of the stated and shared objectives. We suggest a collaborative approach that leverages the resources and capabilities in both the public and the private sectors and across many other divides based on aligned commitment to the policy objectives that we are pursuing as a country and as a nation. The big prize of achieving universal health coverage is one we unreservedly support and commit to. And we also commit to continue to play a constructive role towards its achievement. We support all the five key principles that are reflected there. All of these both strengthen and enhance the entire national health system. They are also excellent benchmarks to keep in mind as we make progress towards a fully implemented national health insurance system. We believe, honorable members, that the private sector should continue to play an important role in building our health system, help retain health professionals, as well as professionals in other sectors of our economy, and make a significant contribution to our economy, including through catalyzing investment across many sectors. As part of our contribution, Honorable Chair, we will be making suggestions on an operating model we believe could mitigate the risks in the current design, whilst advancing the policy objectives that we all seek to achieve. We believe that we should ensure that all South Africans receive the same minimum package of healthcare services, leveraging all the skills and resources and assets that our country has. We believe that the private health sector should play a role in taking a bit of the load off the public sector in the context of South Africa's constrained financial and other resources, and make sure that we work collaboratively in this context to achieve essentially what should be the main focus of everybody, which is universal health coverage. We also believe that this objective can be achieved, given all the constraints that we'll be operating under, if we all implement an affordable, sustainable path that all of us agree on, that is transparent, that is characterized by key benchmarks, but all those benchmarks at any point in time leveraging the resources that we have in the country towards this shared objective of universal health coverage. Honorable Chair, I will now hand over to Dr. Noach to continue with our presentation. Thank you. Over to you, Ryan.
Thank you very much to Dr. Nsaluba. Good morning to you, honorable members, and thank you very much for accommodating our comments and presentation to support our very detailed submission that we have provided to you in respect of this critical structural reform. I thought the starting point is to reiterate something that the members, honorable members of the committee, are well aware of, and that is just how medical schemes are structured and the importance of the delineation between a medical scheme, such as the Discovery Health medical scheme, and the medical scheme administrator, the company for which I work, that I am CEO of, Discovery Health, which is something quite distinct from the medical scheme. The starting point, of course, is to say that medical schemes function under the Medical Schemes Act, as amended in 2006. And this is an environment of an egalitarian set of legal requirements where medical schemes function on the basis of social solidarity, pooling funds and contributions from members in order to function in a community-rated environment. The community rating means that everybody pays the same contribution irrespective of underlying age and demographic risk or health risk for a particular plan. The social solidarity environment, characterized by the hallmarks you see on the right-hand side of the chart, open enrollment, allowing anyone to join with limited underwriting at any stage of their lives, and within this environment of strict solvency requiring 25% annual reserves being held in reserve at the start of the year for all members of the scheme. This environment does mean, as an honorable member mentioned earlier, that the entry price for medical scheme cover in South Africa is indeed expensive. We would not dispute that. An honorable member spoke about this in the previous session, and we support that view. And we very much hope that through the structural reform that we support in the sector, wherein we hope the private sector can have a meaningful role to stand with the state, that we can come up with much more affordable means of financing healthcare. It's critical to point out that in respect of the Discovery Health medical scheme, as shown on the left-hand side, 87% of all funds received go towards paying for the claims of the members of the medical scheme. On a globally benchmarked basis, this actually represents a highly efficient health administration environment, considering that administration of healthcare claims is highly sophisticated and investment is required in order to ensure the efficiency of the healthcare system. As you can see from this chart, less than 10% of Discovery Health medical schemes' total contributions accrued go towards covering the costs of administration and managed care. And in fact, in externally audited and benchmark reports, there is a demonstrable return on investment, a positive return on investment for the scheme of investing these funds in managed care to ensure that the efficiency in the healthcare system is optimal. Next slide, please. So moving on to the role of the administrator in the system as legislated by the Medical Schemes Act in respect of Discovery Health and the contracts we have with 20 medical schemes that we administer, including the Discovery Health medical scheme. The administrator is paid a fixed fee per member per month. It's critical to reinforce, as members of the committee would know, that this fixed fee has no bearing on the claims that are paid out by the scheme. And in fact, that is a legislated requirement. So irrespective of whether a claim is declined or repudiated or paid in full, this has no bearing whatsoever on the income to the administrator, being Discovery Health. The administrator's role is to ensure that the scheme is well governed, well managed, and that the healthcare system is well organized to deliver the most efficient service possible to the scheme. In reflecting on the questions from honorable members of the committee to my colleagues from the Bonitas medical scheme, I thought it relevant to point out some of the specific answers. During the 2020 period benefit year, January through December 2020, based on the Council for Medical Schemes annual report, Discovery Health medical scheme received 401 complaints of the 47 million claims paid by Discovery Health medical scheme during that year. This represents 0, then 5 noughts, and then an 8. 0,000,00008% complaint rate to the Council for Medical Schemes of total claims. In respect of rulings against the medical scheme in the Section 47 complaints process at the Council for Medical Schemes, there were 58 of those heard in the 2020 period, 71% of which were adjudicated in the scheme's favor. So indeed, to the honourable member's point, these are important data points and statistics. The cover ratios achieved in Discovery Health Medical Scheme show that just over 97% of all claims submitted for in-hospital care are covered in full by the medical scheme from risk funds, just over 97%. In benchmarking the role of the administrator, the cover ratio of the medical schemes, and these complaints on a global basis, as our submission demonstrates, we've looked at multiple markets across the world. The medical scheme and the administrator perform extremely well on a global basis. And these are strengths that we think should be utilized and leveraged together with the state to optimize the function of a national health insurance administration system. The medical scheme administrator, in the case of Discovery Health Medical Scheme, collects about 70 billion Rand of premium on a monthly basis and pays about 350,000 claims a day. And so this ability to operate at scale is an important asset that we wish to make available and work with the state on to ensure that the national health insurance can be administered efficiently. Next slide, please. We believe at Discovery that it is critically important to focus on preventative healthcare and to ensure that the health of the nation in general is lifted through the interventions of any funding pool and any funding approach towards healthcare. As juniors in medical school, we were taught that the most important approach to managing any healthcare system is, of course, if you can keep the people healthy, it leads to the best quality of life, the best healthcare outcomes for the population, and of course, the lowest cost in any healthcare system. Our approach towards this is through what we call Vitality's shared value model, wherein we provide incentives and rewards to customers of Discovery in order to change their behavior, to trigger a different type of lifestyle behavior and ensure that they are in fact healthier. And as the charts along the bottom of the slide show, over longitudinal data now spanning more than 20 years, one can measure at many levels through the data the efficiency and effectiveness of this in the healthcare system. Healthier people, those highly engaged in our context with Vitality, have lower hospital admission rates, shorter hospital stays, lower healthcare costs, and importantly, reduced mortality rates. And the outcomes are absolutely critical and central to the structural reform of any healthcare system. This recognition of the power of a wellness program that works this way has led to this wellness program functioning effectively in 22 markets. And we would very much like to work with the state and the national health insurance system to ensure that we can focus on wellness and preventative care together. Next slide, please. Along the lines of a question from one of the honourable members of the committee, we have been contributing meaningfully towards achieving this important concept of universal healthcare for all South Africans for some time. Some of the areas we've been investing in, which we think require more investment, is firstly in the skills base. We do face capacity constraints, as previously mentioned, from a health professional and professional resourcing perspective in the sector. And over a period of time since 2006, we've invested substantially to support the training of 400 medical specialists who are now working primarily in the public sector. We tell the story to the committee because we think more of this needs to be done collaboratively as a contribution from the private sector to the public sector working together. We have also developed through the private sector multiple tools to create efficiency in the healthcare system. These include sophisticated digital tools, but also health analytical and health measurement tools. And the power of these health informatics was particularly evident through the COVID period. We think going forward, there should be a shared experience in digitization, in contracting of provider networks and the sophistication involved in that, and in the deployment of value-based healthcare metrics and tools through the healthcare system to benefit all South Africans. And of course, we must work together to expand access to healthcare to achieve this vision of universal healthcare. And many of our activities demonstrate our bona fide belief and contribution in this regard. Next slide, please. It is critical to say that through the COVID-19 period, the solidarity between the public sector and the private healthcare sector has revealed fundamental changes that are needed across the sector. We are committed to structural reform, and we believe in the need for structural reform in both the public and the private sector, equally and across the board, to ensure universal healthcare coverage and to strengthen the healthcare system for a successful NHI. Some of the areas that became evident through the COVID-19 collaboration included these headings across the slide. Importantly, working together to understand financing models and funding capacity that jointly between private and public collaboration can be optimized and can contribute meaningfully back to the fiscus, both in terms of employment of South African people, and the private healthcare sector in South Africa currently employing hundreds of thousands of people, and also in terms of tax contributions, which exceed 75 billion rand from the private healthcare sector today, and should be maximized and optimized in the structural reform to make sure that the good of all South Africans is curated as we achieve universal healthcare coverage. Capacity is key, as I've mentioned previously. We have seen the need for simultaneous regulatory change across private and public. And critically, we do need to invest together to reduce the burden of this quadruple burden of disease that we face here in South Africa quite uniquely, and particularly also of non-communicable disease, as alluded to previously. Next slide, please. And so the insights from the COVID-19 vaccination campaign, something that has happened subsequent to and after the drafting of the current NHI bill, we think have direct relevance to what is contained within this NHI bill. And there are important learnings for all of us in the healthcare sector. Social solidarity is a requirement, and to do this, we need to continue the strong public-private collaboration that we saw during vaccine access. The entire healthcare system must work towards social inclusion. There must be equitable access and care, and the same quality and type of service available for all South Africans at the point of delivery. We must be able to demonstrate value for driving economic growth in the healthcare system, sustaining a productive and healthy workforce. We realize that the private sector and the public sector together can stand together and augment capacity jointly. And as the president said in his very own speeches, the role of the private sector in vaccination was immeasurably important in respect of the COVID-19 vaccination effort. And lastly, something that became clearly apparent is sharing of data across all sectors of the South African healthcare system bodes well and importantly for a much better integrated service delivery and financing mechanism. At this point, as Dr. Nsaluba said, let me hand over to Professor Roseanne Harris, the head of health policy at Discovery Health, to speak to some of the technical aspects of our proposal.
Thank you so much, and good morning, honourable members. Thank you for this opportunity.
Sorry, Professor Harris, before you do, I noted chat from a Sandhya Singh on the chat platform, noting escalating burden of disease. Discovery may wish to amend the prior slide. Now, I'm not aware that this Ms. Singh had been introduced as a member of your team, but if you, as you go along, can maybe just answer this point so that we are certain whatever is mentioned on the platform is coming from yourselves. Thank you.
Thank you, Chair.
Please continue.
Thank you. So we have several platforms for collaborative action towards building a sustainable and resilient health system. And these have already been established and are including multiple stakeholders in the sector and are action orientated. And as Dr. Noach has said, this is a momentum we can't afford to lose as we hopefully move into a post-COVID era. The Presidential Health Compact established 9 pillars of work with clear action plans for all stakeholders to work together in addressing the challenges in the healthcare system. And we can also be proud of the collaborative efforts of the Solidarity Fund, which was really important in battling the pandemic, and the COVID-19 Alert app as other examples of this public-private collaboration. 2019 also gave us some additional resources for health system strengthening, namely the Lancet Commission report on quality care and the Health Market Inquiry report. These have valuable and detailed recommendations for improving efficiencies in the private sector, which will enhance affordability and promote quality of care. And this is a very important opportunity for us to uplift the system overall by enhancing the funding that's available for everyone. We suggest that there is dedicated focus on actioning these recommendations. So next slide, please. So let's have a look at some of the international experience. This slide illustrates the policy choices on health systems funding that have been made by a number of other countries. And we've set out quite a lot of detail in our submission about the structure of these systems. There's no single correct way for us to achieve universal health coverage, as the appropriate structure is going to depend on things like the structure of the economy and the needs of the population in any country. But we've worked on drawing some key learnings internationally to help us develop an appropriate incremental model for South Africa. The column labeled dominant public provider is the choice codified in the NHI bill, a single funder model with a small separate role for private insurers. However, it's notable that not a single other country legislates the scope of private health insurance. And there's good reasons for this. Most importantly, the service delivery risk for citizens. In the UK, for example, there's no legislated limitation on what health insurance covers, and people are able to choose what cover they want to purchase to supplement their NHS access. So the current model that we have at the moment can be considered to be a parallel funding model, but we have an incomplete social solidarity framework which limits the opportunity to derive full benefit from this model. The blended funding model provides greater opportunity for cross subsidies rather than the responsibility for funding being borne mainly by fiscus. This also creates the opportunity for employer involvement in funding and provision of care. As Dr. Noach has highlighted, our COVID experience has demonstrated the feasibility of virtual pooling across public and private, with service provided free at the point of service. I'm going to provide a bit more detail on how this could work a little later in the presentation. Of course, there's benefits and risks associated with any system, and the aim is to maximize the benefits and minimize the risks. The key point to note is that there isn't another country in the world that has limited the role of private insurance through legislation. In other countries, citizens are empowered to make those choices. So we're not arguing that people should be able to opt out of paying for the NHI, but rather that we understand the important social solidarity of everyone contributing according to their means, but that South Africans should have the opportunity to purchase private cover when they have the choice to do so, and that this should be structured to be an integral part of an integrated health system, and that overall that will enhance the benefits for everyone. So let's have a more detailed look. We currently operate on the basis of a parallel funding model, and the risks identified here on this left-hand side of the slide are familiar to us, particularly with respect to inequality and inflation, as have been highlighted in a number of the points made earlier this morning. The dominant public provider model also has some risks, such as lack of consumer choice, lack of competition, the issue of monopsony power, which does not guarantee efficiency, since it eliminates the opportunity for selection of efficient providers in the market. So it undermines the opportunity for strategic purchasing, in our view. For example, provinces currently have the opportunity to contract with private pharmacies to support primary care and chronic care, because there's been a market to support the establishment of these service providers, and they can demonstrate their capacity to provide the services.
If there's
no such market, I guess continue, maybe we can mute. If there isn't a market that can develop these
Sorry, apology for that. Continue.
I've been muted. Sorry, I hope you're hearing me now.
I can hear you now. Sorry about that, Professor Harris. I had to correct something. Continue.
No problems. Thank you, Chair. So if there isn't a market once the monopsony purchaser has made their purchasing decision, then there isn't the ability of other providers to demonstrate their capacity unless people are purchasing services on an out-of-pocket basis, which of course is highly regressive and something we want to avoid. Also, the incentive for innovation is limited since there's no scope for demonstrating the benefits in a competitive market. And the single provider creates concentration risk in an environment where there is rapid development of new treatments, such as in the healthcare space. So essentially, the single model is likely to create implicit rationing, leaving citizens with no legal alternative and possibly creating perverse incentives to access care. So we're suggesting a more nuanced approach, as shown in the blended funding model. This requires an integration between public and private sectors, similar to what we've achieved during the pandemic. And this would leave all consumers with some choice and improved access for all. Additionally, it would leverage off the current social solidarity medical scheme framework to accelerate the attainment of UHC. So let's have a look at some of the numbers. Here we add the financing amounts based on the 2020 experience to all three funding models. The elimination of the medical scheme cover through Section 33 of the bill would mean a funding gap of 212 billion in the system, in the healthcare system, which is around 4% of GDP. Of course, it's unlikely that this amount would be entirely recouped through additional taxes because it would require an additional increase in personal income tax by over 40%. So maintaining the medical scheme framework, but with improvements to the regulatory structure to enhance its efficiency and affordability, would mean maintaining voluntary funding into the medical schemes, as well as funding from employer contributions, which then enhances the funding in the system as a whole. So let's have a look at some of the principles of universal health coverage. Our view is that it requires the supporting pillars of affordability, accessibility, and quality outcomes for the full benefits to be achieved. And this is important in defining a model to minimize the risks. So looking at these in turn, affordability requires us to focus on primary care, ensuring public funding is directed to those most vulnerable who are not able to provide for themselves. We also need to be quite realistic about encouraging additional funding, and we need to build on what we have to make it work better, harnessing the private sector with improved efficiencies. Accessibility means ensuring that we leverage our resources and embark on collaborative planning to identify where there are gaps in care and service priorities, which are based on what people really need. And the third pillar is measuring quality outcomes in terms of population health and ensuring that the healthcare providers are appropriately incentivized to be partners in delivering care. All of this is underpinned by investment in capacity building and a sound governance framework. And we believe that the transitional NHI model structured on a multi-fund approach is the best way to achieve this. So let me try and describe this in a bit more detail. Under this model, there's no opting out of funding NHI, but there is the opportunity to provide additional cover. The NHI fund receives a mandatory contribution from everyone who can afford it and is also supported by tax funding to cover the whole population. Virtual pooling is achieved by having a common service package with regulated costing and pooling of risk on an appropriately managed basis. Those who are able to afford to fund themselves can contribute to medical schemes, which are obliged to then fund any cost of the NHI benefit package which is not covered by the mandatory contribution. This protects the NHI fund from high utilization levels of those with more access to care, thereby focusing the NHI's resources on those who are unable to afford their own provision, but supported by progressive cross subsidies. We've drawn on the experience in countries like Chile, Brazil, and Thailand, but it also enables the benefit package to be service-based, like what we see in the UK's NHS. Importantly, this preserves that people are able to access care under the NHI benefit package at the point of service, with the funding arrangements happening in the background, as we've seen working successfully with the vaccine program. This framework does therefore not perpetuate a two-tiered system for the delivery of the NHI benefit package. From a delivery perspective, there's an opportunity for multi-fund contracting to deliver value through managed competition, but on the basis that there is an NHI reimbursement framework to limit the kind of adverse consequences we see currently with the medical schemes having to pay PMBs at cost. This, along with the HMI recommendations, the recommendations of the Health Market Inquiry regarding provider contracting, will encourage healthcare providers to develop innovative approaches to value-based care, which is then accessible to everyone. The structure will also mitigate the risk of out-of-pocket expenditure increasing to address benefit gaps, as we've seen in other markets where single fund approach has been adopted. So there's certainly lots of details to work out, but we do believe that this is a workable and affordable approach that is entirely consistent with the UHC policy objectives. And it also minimizes the risks associated with breaking down our existing social solidarity risk pools. So we believe that this model will address the NHI objectives as set out in the white paper and the preamble to the bill, in that we've got mandatory participation for a common package, we've got mandatory contributions into the NHI fund, we've got a single risk pool for benefits across both the fund and medical schemes, and equity by ensuring the appropriate direction of cross subsidies. And there's also an opportunity for extended financial risk protection with a single package regulated with a regulated reimbursement framework. It's also more sustainable than a single fund approach due to the additional benefits of reaching the wider number of, reducing the number of claimants that are dependent on public resources, and also retaining a private healthcare sector with opportunities for equitable access so that we can harness the benefits of managed competition, promote efficiency, and leverage the expertise in the private sector. So as we consider then a transitional framework, if we go to the next slide, the proposed restructure of the health system towards an NHI framework is a really large undertaking, and it does require cooperation, not just across public and private, but also multiple spheres of government, the health system, and the broader society. We've noted a number of key references for these actions. I've made reference to the HMI, the Lancet Commission, the Presidential Health Compact, and we're very keen to support this transitional process. We strongly advocate taking concrete steps to solidify the kind of cooperation that has emerged during the COVID-19 crisis, which includes putting in place the planning for human resource for health development and the recommendations of the Health Market Inquiry. There's been extensive ideological debate around the endpoint, but our view is that we actually do have sufficient consensus now on the important principles to take steps towards implementation. And we stand ready to support the honourable members in the committee in putting this in place. So let me just address a few points around Section 33 of the NHI bill. We certainly do agree that the costs of private health insurance are unaffordable for many South Africans, and the Health Market Inquiry has identified that the incomplete implementation of the social solidarity framework has been a driver of inflation. Their recommendations have included encouraging value-based reimbursement frameworks. And in addition, there's a number of opportunities to immediately expand access to cover in a way which is consistent with the objectives of the NHI Fund and in a collaborative way with business and social partner stakeholders. The reasoning behind the new inclusion of Section 33 as it's worded in the 2019 version of the bill compared to the 2018 version of the bill hasn't been clarified. And we're concerned that this may have been based on a number of assumptions which are not necessarily founded. Some of these include that the assumption that it's been assumed that limiting the role of medical schemes will solve the maldistribution of health professional resources between the NHI and the private healthcare system. We certainly agree that it's a reality, the maldistribution of resources, but the challenge is that there is a dire shortage of health professionals across both public and private sectors, and limiting the role of medical schemes will not necessarily solve this problem. The research conducted in the healthcare system suggests that factors such as working conditions and clinical support are really important. And there's simply not enough health professional resources in South Africa. So as public and private, we need to urgently work together to address this rather than suggesting that just requiring health professionals to work in the public sector will address the challenge. It's also been assumed, or it seems to have been assumed, that limiting the role of medical schemes will improve inequalities and equities in the system. And we're concerned by the assumption that the NHI bill will lead to a redistribution of medical scheme contributions. These are voluntary contributions paid by medical scheme members and mostly out of after-tax income. If it's not paid into the medical scheme, the money will be retained by the people who currently belong to medical schemes unless it's collected as taxes. But even then, redistributing all the medical scheme contributions across the entire population is still going to be insufficient to achieve the NHI objectives. So we do need to look at a collaborative approach to funding that is more feasible. And finally, there's been assumptions about the demographic structure of the medical scheme population. And a number of presentations have clarified this, referencing the General Household Survey with regard to the racial distribution, but also important to note that this source confirms that 50% of medical scheme beneficiaries are from households with income of less than 30,000 Rand a month. So we're very concerned that there seems to be a focus on removing medical scheme cover and that it will somehow improve the funding of the NHI. This would impact all sectors of society and it would result in more people relying on the public sector. Looking at the right side of the slide, we can see that South African healthcare costs are considerably lower than in many countries. So it's not correct to state that private healthcare in South Africa is amongst the most expensive in the world. The cost of private cover in South Africa is actually lower than the health system costs in the UK in absolute terms and on a purchasing power parity basis. So access to private healthcare is undoubtedly an attractive factor for prospective investors in South Africa. And we really do need to be thinking about how we can attract investment into our economy. So we believe that this is an important asset, and we certainly implore honourable members to carefully consider the consequences of the policy uncertainty to this important sector in our economy. So moving on to look at out-of-pocket expenditure. It's not the case that the majority of medical scheme members are running out of benefits before the end of the year. Looking at our statistics across the Discovery Health administered schemes, we find that the majority of members have positive benefit balances at the end of the year with regard to their day-to-day cover. PMB regulations mean that members are covered in full without any limitation for over 300 diagnoses and also for chronic conditions like diabetes, heart conditions, asthma. We see payment of these benefits happening at a consistent level across the year. These PMBs require adherence to clinical pathways in order to receive the full benefits, and this is entirely aligned with the NHI proposals in Section 6 and 8 of the bill. It's also important to note that medical scheme members do not routinely face crippling out-of-pocket expenditure. There tends to be full coverage for serious events, and it's more discretionary items such as advanced dentistry and spectacles and other allied services where members pay out of pocket according to the choices that they make. Expensive new treatments are also carefully evaluated for efficacy and affordability. This approach to benefit development for a sound risk pool structure is also likely to underpin the NHI benefit package. So we're very concerned about the risk of unintended consequences associated with the construct currently of Section 33 of the bill. The maldistribution of practitioners may well be exacerbated rather than addressed. And we've experienced a significant brain drain of health professionals, with many South African trained health professionals working around the world. Increasing taxes will also have broader consequences for the economy. And so we strongly support a phased implementation, and we're concerned that there may be unreasonable expectations with regard to the level of benefits that can be afforded. And then importantly, removing the tax credits has consequences, particularly for those earning under 300,000 Rand per annum. Independent research has demonstrated that just under 500,000 people would lose cover to fund their private care out of pocket, resulting in increased catastrophic expenditure if we were to remove the tax credits at the moment. It's important to note as well that the tax credits reduce the tax paid by members and are not paid to medical schemes, as Section 49 of the bill incorrectly states. And I think that's an important point as it came up in the discussion earlier this morning. It doesn't impact the income of the medical schemes, it impacts the individuals. And it's also a progressive structure in that it creates access to cover for low-income earners and was successfully restructured to do so by National Treasury several years ago. So removing the medical scheme tax credits will actually increase the burden on fiscus, as the cost of funding care in the public sector for these people is actually higher than the tax credit. So it would be somewhat self-defeating to do away with the medical scheme tax credits, but we do support considering an income-based restructure to support affordability, as the Health Market Inquiry has recommended. Moving on to look at a few other consequences. Healthcare funding is extremely complex, and it's our hope that the establishment of the NHI Fund will create a framework for robust and detailed discussions on the to construct concrete steps for improving healthcare. It's important to look at the experience in other countries, like when we look at the experience in Ghana and the increase in out-of-pocket payments that escalated with the introduction of a single fund model. And this is something that we really need to avoid. Lower income medical scheme members also rely heavily on employer subsidies, and they are important partners in ensuring access to care. So this group would be particularly negatively affected if they lost these subsidies. So we suggest that we should be looking at ways to expand access to these subsidies while also expanding care to the most vulnerable in our society. So looking at some of the societal repercussions, Section 33, the impact of Section 33 does extend beyond the medical scheme members, because the migration of healthcare professionals would also reduce access to care for everyone in society, and the loss of experienced specialists compromises our training platform. Single payer market could also depress innovation and dampen investment, and there is an increasing risk of catastrophic expenditure. So we don't want to fragment the healthcare system further, and we are advocating for more integration and health system reform towards an integrated structure. So let me have a look at some of the more detailed recommendations. And I'd like to stress that we really support the establishment of the NHI Fund as an entity, and also this phased approach that's been proposed for developing a package of services that is delivered through both public and private healthcare providers. But we don't support the limited role of medical schemes, and we feel that the objectives can be enhanced, and the evidence supports this in terms of a role for the medical schemes. So we have included in our submission detailed recommendations regarding the wording of the bill, and we suggest that this should improve clarity of intent by establishing the NHI Fund and focusing on that implementation, but also an ongoing role for medical schemes under an enhanced social solidarity framework. Also ensuring that there's governance provisions to reflect the need for the technical skills and capacity for this large and complex task. We also suggest that the bill needs to be clearer on key aspects such as the definition of benefits and funding, and that the bill seems to be overly complex in matters such as provider contracting, which are effectively hard-coded. We rather suggest that the appropriate models need to evolve. Also, the omnibus approach to legislative amendments could be considered as premature and maybe should be considered once the framework is in place. A clear and collaborative program of health reform will significantly enhance investment in the sector and expand access to effective delivery of healthcare. And we believe that this should be the motive to drive us all. So looking at specific recommendations with regard to Section 6 and 33, we've noted that Section 33 of the bill does introduce significant uncertainty, and as I said, we have made constructive recommendations regarding how the role of medical schemes can be incorporated. And we implore the honourable members to ensure that there is a clear and substantial policy rationale as we move forward. Certainly, we've made recommendations around amendments, and we'd be happy to engage on those further. Some other detailed recommendations. The NHI bill proposes a reorganization of funding of healthcare in South Africa, and yet the National Treasury paper to substantiate the implications of these impacts on our economy has not yet been made available. So we'd urge that consideration of this Treasury paper and the public input on it is part of the implementation process that is considered in the first phase. We've also made recommendations regarding the governance framework and the importance of ensuring that this entity, the NHI Fund, which will have revenues in excess of those of Eskom, will have the necessary technical and management capacity and appropriate oversight to focus on efficient healthcare delivery to South Africans without political influence. The milestone dates in Section 57 of the bill are also inappropriate, and we support a phased implementation that accommodates lessons learned. So it needs to be driven perhaps by clearly defined milestones rather than by dates, and milestones related, for example, to access and quality of care. And finally, we're concerned that there's a raft of proposed amendments to other legislation which can have the effect of removing cover that people currently have before there is an alternative in place. In particular, we're concerned about the immediate removal of maternity cover from medical scheme benefits. Such amendments also transfer large liabilities to taxpayers, so the cost of these needs to be properly quantified and planned for. So we suggest that the NHI bill should be simplified to focus on establishing the entity and not to necessarily impact the rights of citizens in accessing healthcare now. So just to close off from my side, we believe that there's some immediate opportunities and actions that can make a significant difference to the affordability of cover and delivery of value-based care. And we urge the honourable members to push for action on recommendations from the Health Market Inquiry with respect to things like the HPCSA rules on multidisciplinary teams, as well as with respect to telehealth opportunities and the benefits of appropriate clinical use of digital health tools. This will enable the capacity to be built for contracting for services as envisaged in the bill, and it'll start addressing inequality in access to care. We'd also encourage the establishment of the advisory committees as envisaged in the bill, and this could be an urgent priority to work collaboratively on building the system capacity that we need to action the items in the Presidential Health Compact. So I'm going to pass back to Dr. Nsaluba to close out our presentation. Thank you.
Thank you very much, Roseanne, and thank you very much, Ryan, also. Honorable Chair and honorable members, I think the point really that we are making is that we fully support universal health coverage and the overarching principles set out in the NHI bill. We also recognize the need for structural reform and were supportive of that. We believe that we should build on the important lessons that have been learned as we mounted a national response to COVID-19, and my colleagues have alluded to some of those learnings. We believe that we need to have a collaborative phased implementation of the bill. And more importantly, we believe that there should be simultaneous progress on the creation of the NHI fund and the implementation of the market inquiry recommendations, so that we can make sure that the private and the public sector act in a far much more synergistic way. We have pointed out what we consider to be the risks associated with the single payer model. We've highlighted what we believe should be considered in terms of improving governance and accountability of the fund. And also we've spent some time trying to give some detail on what we propose, which is the blended funding model. So, Chair, I really think that is the input that we'd like to make. And we stand ready to respond to the questions that committee members would have. And just once again, to thank you sincerely for the opportunity provided and afforded to us so that we can make our own contribution to this discussion. Thank you very much, Honorable Chair and members.
Thank you very much, Dr. Nsaluba and your team. We thank you for coming to do this presentation today. There are quite a number of members who would want to raise some questions with you. I'm going to name them in the order. And then I just want to first go to slide 4 with you. And then at the end, I will be raising more questions with you. So maybe at this point in time, you can get slide 4 on the screen for us. It would be Honorable Slengwa, followed by Clark, Wilson, Harvard, Hela, Siwela, Munyai, and Sukacha. Honorable Slengwa, Clark, Wilson, Harvard, Hela.
And myself, Chair.
Oh, have I missed you?
Yes, you have.
Yes, because I see Wilson mentioned twice. You were probably in the beginning. You number 3, if I'm correct, and it doesn't really make a difference. Honorable Wilson will be, or you can just take the spot I've given to Wilson. So let me repeat. Slengwa, Clark, Wilson, Harvard, Yela, Ismail, Siwela, Munyai, Sukacha. I see you have switched on your camera, Honorable Slengwa. So I would assume you'd want to ask a question.
Yes, thank you.
You're right in the beginning. Fine, I'll deal with that question, that slide 4 towards the end then, Honorable Slengwa. You may continue. Thank you.
Thank you, Chairperson. Let me welcome the presentation from Discovery. I have only one seeking clarity question. What is your view or interpretation of Section 7 of the bill, which provides that a user must adhere care service providers or health care or health establishment and is not entitled to health care service passage by the fund if he or she fails to adhere to this prescribed referral pathway. My question is this: what is your interpretation of this specific section? I thank you.
Honorable Clark.
Thank you, Chairperson, and thank you very much for a very detailed presentation and very interesting, might I say. Firstly, Discovery has done extremely well in implementing strategies that encourage its members to live a healthier lifestyle through vitality. In your view, what provisions does the bill make to focus on preventative health or ensuring that, or encouraging that South Africans live a healthier lifestyle? This, of course, can have a positive impact in lowering the healthcare burden. What are the costs saved due to Discovery's effective preventative health strategies? Is it something that we are able to measure? In your view, does the bill adequately cover preventative care? There is mention in your presentation that in order for the funding model to be sustainable, there is a need to include the private sector. Considering the current structure of the bill, what consequences do you foresee if the private sector's role remains as stipulated in the bill? There is a mention that there is no country that has implemented a regulation limitation on the scope of private health insurance cover. What reasons do you believe that no country has done this? And I've listened very carefully to your blended funding model, and I found that recommendation very interesting. And would you say if that blending funding model, the key points are implemented within the bill, do you think that would strengthen the bill's achievements and outcomes in terms of its objectives? As a consequence of the single payer model, there is a mention that it will lead to a lack of competition. What consequences on the delivery of the quality of healthcare services do you foresee in the current model? You also spoke about migration attributes to the attempts to limit doctors in terms of their earnings within the private sector. Has there been any discussions in terms of your medical service providers around this matter, and what was the outcome? How would you simplify the bill in terms of the uncertainties of the NHI service package, as well as within Section 33 and other sections of the bill? What is your view in terms of the powers given to the health minister? Would you support the powers given to the minister, or would you make certain recommendations around this matter? Thank you, Chairperson.
Thank you very much, Chairperson. A lot of my questions are covered by my colleague. There's a couple of things I would like to still discuss, though. And I predominantly want to go to your universal health coverage, and in particular, the 3 pillars that you said were essential to make universal health coverage effective, and I 100% agree. However, they were, accessibility was one, quality of healthcare was the other, and then of course there was the pillar of affordability and sustainability. Now, principally, if you look at the current health system, none of those pillars are in place. There is not easy accessibility to health facilities in this country, public health facilities in this country, let alone private health facilities. The quality of healthcare being received by the general public who are going to public facilities at the moment is not of a good standard. with medications unavailable, resources unavailable, beds unavailable, and just simple things like linens and things being unavailable. And of course, we know that it's not, our current health system is not as affordable or sustainable. And I'm talking about that from a government perspective, where we've seen our budgets have been cut, both, you know, in terms of human resources, infrastructure, budgets, and all of those kind of things. So instead of improving our health system at the moment, we're actually going on a backward trajectory, which is hurting the general South African quite severely. And relating that to your dominant funding model, which is where we seem to have placed NHI in this country, it was quite an interesting example. You know, it was something that was quite valuable, particularly in the fact that in the UK, for instance, and this portfolio committee has often talked about the UK model of universal health coverage. And in fact, we were due to go and have a look at it before COVID struck us. And I think it's very important to note there that there is a smaller demand for private insurances there because people have accessibility, far easier accessibility to public health systems that is not available in South Africa. And Ghana, of course, being the exact opposite. So the question there is, surely then, before we can start implementing the NHI, we have to have the three very basic pillars, three very, very important pillars on a very strong foundation before we can start considering the implementation. Now, we've had a lot of discussions that it's a slow process and you do it step by step and, you know, you implement it in stages. But if your very basics, if your foundation is already in the quicksand, do you agree that this will pose a problem? And I'm glad you raised the maldistribution of health professionals. This is something we've had long discussions about in this portfolio as well as in Parliament. And quite frankly, it's going to continue because of the under-resourced public facilities, the distribution of public facilities. Our health professionals, you're quite right, are very wary of going to work there. We have medico-legal claims in South Africa that run into billions. And nobody wants to be at the back end of a medico-legal claim, particularly when it could have resulted in lack of resources, lack of availability, and all of those kind of things. And I'll use Livingston Hospital as an example. They have now stopped the orthopedic surgeries, particularly things like joint replacements, knee replacements, hip replacements, to name a few others, and will only now do accident trauma and surgeries as a result of recuperations, etc., from operations. So we have hundreds and hundreds of people, they're immobile, some in wheelchairs, some on crutches, etc., who cannot go into that facility. It is the biggest hospital in the area. It has an orthopedic wing that is non-operational. It's non-operational. So those are the kind of things, and I'm using these as an example to support my point. So it's hardly surprising that we have a maladministration of health professionals, because nobody wants to work in those kind of situations. And we can't even employ our graduates in this country at the moment. So that is, I'm glad that you raised it, because I think that is critical. There are qualified doctors, very well, highly qualified doctors in the country who make applications for posts all of the time. And they are being rejected on a myriad of excuses while the people of South Africa suffer. Your presentation was very, very enlightening. And I'm very glad that we dealt with some of the misconceptions. I think that was very important. And I think some of us probably have a better understanding now of how medical schemes are run and the different definitions of the administrators and the fund itself. And just finally, I want to reiterate what my colleague, the Honourable Clark, stated on the competitiveness in the bill with regards to having the government as a single purchaser. And I think this is alarming. I think it's something that must be considered, because this is going to obviously hinge on price. Some people are going to be able to supply cheaper. Quality issues need to be taken into place, and with this department's history of corruption in recent times, I think that needs to also be eliminated. So I thank you all round for a very good presentation. Thank you, Chair.
Thank you, Chair. Happy New Year for everyone. Welcome to Discovery presenters. I have 3 questions here. First one, you are worried that there is no incentive for innovation on the single-payer NHI model. Can you share with us the basis on this conclusion? Second one, can the presenter please point us to the section in the bill where it is stated that medical schemes serve a population that is predominantly white? The last question, what does the term universal health coverage mean to Discovery? Should there be a 2-tier system? Thank you.
Honorable Gela. Honorable Gela, you are next. We will move on to Honorable Ismail and come back to Honorable Gela.
Good morning, everyone, and thank you for the presentation. I just have a few questions, very basic. I've been covered by my 2 colleagues previously. So my first question, what are the key features of the NHI that will result in, more equitable access? Do you think it will further widen the inequality gap due to the accreditation system? What are your thoughts on this? My second question, do you feel that the bill should be more explicit on price setting mechanisms for the determination of prices, for healthcare services? What do you feel should be more specifically specified or defined in the present bill? Do you think perhaps the inclusion of the private healthcare sector? My third question, I've gathered that you support a more hybrid system. Do you believe that a hybrid system will be more effective in creating equitable access to healthcare? In your view, will it also improve health outcomes? My fourth question, how do you feel medical aid should be more included in the current bill? As you stated in your presentation that medical aid should be included, in the bill. I'm just querying as to what would you like to be more specified in the bill? And my fifth question, in what ways do you foresee the fund being vulnerable to corruption? And what strategic measures should be put in place, to address this? My last question, as the NHI stands, how do you foresee the quality of healthcare? It can be argued that it will create equal access, but what are your views on the quality of healthcare access with this bill? We know right now our healthcare system is basically, suffering. We have a shortage of beds, shortage of linen, shortage of basically, our patients are actually waiting in lines because of the delay in operations and so forth. What about the litigation costs? And I mean, if you're just looking at the SIU report today of the PPEs, the amount of corruption right now in our healthcare, system, or in the way what we're looking at now in the country. Do you really think the NHI will work, although it will be, specified, or as it was specified in the bill, that it will be brought in stages? Do you really think that our country, in its current form, we all know it's going to take a long time for our healthcare system to actually pull up its socks, if I can put it that way, and actually meet the healthcare requirements that we would like? Do you think our country is really ready for the NHI? Thank you, Chair.
Thank you very much. Before Honorable Siwela comes, Honorable Gela is back, and then followed by Honorable Siwela. Honorable Gela.
Thank you very much, Chairperson. My apology, the network, it seems it's a problem on my side. But firstly, let me welcome the presentations done by Discovery. You have provided a valued input and raised important questions. Thank you for your participation in this process. You're concerned about the implementation of medical schemes is acknowledged. Are you aware that the NHI bill does not intend to eliminate medical schemes? Section 33 of the bill states that once the national health insurance has been fully implemented, as determined by the minister through regulations in the Gazette, medical schemes may only offer a complementary cover to services not reimbursable by the fund. My next question, you have raised a worrying issue about a possible funding gap of 212 billion, which will need to be absorbed by the state. Chapter 10 on the bill outline the chief source of income for the fund. Are you perhaps not in agreement with Section 49? Our understanding is that the majority of the NHI budget is already in the health system. Additional funding will be required. But what is your bias to estimate the gap of 212 billion? My other question, Chairperson, my last question, Chairperson, my understanding is that if people on margins leave medical schemes because they can no longer afford it, then under NHI, they will still get their care as NHI will purchase from both public and private providers. Surely increasing public funding of health will surely provide people with protection. What is your view on this stating? Thank you very much. What is your view on this understanding? Thank you very much, Chairperson. It's just I'm driving, but thank you for the opportunity. My apology because of the network connection, but thank you for the opportunity.
Chairperson, thank you for the opportunity. And I have got 3 questions to ask. The first question is, can the presenters explain how monopsony power will prevent purchasing from private providers? Secondly, in the funding model slide, can you explain how you have factored in the current funding of the public health system? And lastly, reading the bill as a whole, as it should be, what are your objections to getting rid of a 2-tier system that discriminates against the poor? Are your profits more important than solving the problems of poverty and inequality in South Africa? Thank you, Chair.
Thank you very much, esteemed honorable members and our chairperson. And we note the presentation. Can you hear me, Doctor? Chairperson, can you hear me?
Yes, we can hear you very well. Please continue, Honorable Munya.
I want to raise the additional question for Discovery. In the slide number 11, you have reflected on some of existing healthcare system in other countries, and you seem to suggest that Discovery is concerned about the regulation of the scope of the practice of the private health insurance institution. By implication, in this specific part of the presentation, Discovery appears to suggest that the private sector setup and status quo should continue to prevail, with the potential for duplication, fragmentation of services offered by the private sector and the accredited service providers under NHI. My question is, therefore, what makes Discovery hold such a view to retain such inefficient, inequitable, fragmented healthcare systems? My other question, Honorable Chair, is the following. It reads as follows. From your presentation, it is evident that Discovery unequivocally support the private healthcare private sector systems in the main and maintains the status quo. I want to focus on what is termed non-healthcare costs, such as administrative costs, which Discovery is the beneficiary of through the private sector. In 2020, the Council for Medical Schemes has reported that every 100 cents, 81 cents was to spend on actual claims, and 8 rand of non-healthcare expenditure, or 8%, correctly stated that the presenter, and 10 rand, or 10 rand on the reserves. The non-healthcare cost, including administrative costs, managed care, broker fee, and marketing costs. These non-healthcare costs increased by 3.6% from 13.84 billion to 14.535 billion as reported by Council for Medical Scheme in 2020. The question is, why will Discovery kill the goose that proverbially lays the golden egg under the NHI as a single purchaser that is publicly administered? I must also say, ask the following question, Honorable Chair. You must please bear with me because my scribbling is scattered here, so I must be able to look it appropriately. Can Discovery state categorically clear that their opposition of the 2017 NHI policy, or what is called white paper, as a government policy? Your opposition to the bill is explicit and unequivocal in your presentation. But I must also say, I must also add lastly, Honorable Chair, COVID-19 unprecedented consequences are the fundamental reason why we should press ahead with NHI. For example, the overwhelmed infrastructure in both private sector and public sector during the COVID-19 is exactly why we should implement NHI. Do they as quickly as possible? Do they agree? Members of your organization pay out of pocket when the medical aid is exhausted. I have a sister here at home. As a practical example, I can give you details if you contest this view. Members of before the end of the year, I have my sister here in my family that I know is for fact. It's happening. We have to give them money to go and really look after themselves, while your own Discovery, medical aid would have been exhausted before the end of the year. NHI policy reform is not proposed for Discovery, but for the rest of the population. The posture of the Discovery in this meeting, it seems to be that they want NHI or the implementation of the NHI that, for instance, to be done by themselves. That posture for me is quite dangerous because the bill, policy reforms, for instance, It is for all. It is for all the population. And the medical role has been accommodated to play a role amongst other complementary roles. The government cannot outsource this policy implementation by the private medical aid. That we will contest to the T here in Parliament as a site of struggle for policy reform. You know as much as we do that private sector medical aid get 8% of the GDP, amounting to over 400 billion to save the few population served by the private medical aid. This bare racial two-tier system is inconsistent with the country's constitution. National Treasury can't be the stumbling block for us to implement the policy reforms such as NHI. Those that are deployed in government must fund the money. Overall Discovery know that all the policies are implemented based from the money that comes from the general taxation. So there's no confusion on that matter. I should stop there, Honorable Chair.
Thank you, Honorable Chairperson. Let me also welcome the presentation from Discovery. Just a few questions from my side, Chair. The first one, many medical scheme members have over the past years approached government with requests for government to intervene because medical schemes such as Discovery requires patients to co-pay amounts up to 30,000 per month for some of the treatment received. This despite these patients being enrolled in the highest tier of benefit within the schemes, thus paying the highest possible amount any scheme member could pay for the membership within the scheme. Now, the question to Discovery is, if these are circumstances forced by patients in the private sector, why should the current medical scheme system be retained as is when it is evident that it is not benefiting the consumers and patients optimally as it should? Then the second question, we have received reports from patients and practitioners groups that medical schemes such as Discovery directs a substantial proportion of funding towards non-healthcare costs and investments. They have instructed that managed care system is in fact a way to deny healthcare to your members. I would like to have your comments on this. Then my third question, Honorable Chairperson, to Discovery is that does Discovery recognize that the bill is an enabling legislation that will not be implemented in its entirety in the first year? It provides for transition. Does Discovery recognize that? And my last question, Honorable Chairperson, is Discovery mentions Section 33 of the bill as stating that some of the funds currently paid towards the medical scheme's membership will automatically be transferred into the NHI fund under the NHI. I wish to caution that it is important for Discovery to accurately quote the contents of the bill. Just to clarify, Section 33 of the bill addresses the role of medical schemes under NHI and nothing about funding. This is addressed in Section 48 and 49 of the NHI bill. Thank you very much, Chair.
Thank you very much, honorable members. Did I miss out on any member? Not for follow-up, please, just those I could have missed out.
No, I'm covered, Chair. Thank you very much.
Thank you very much. Dr. Nsambula, I asked earlier that we just look at slide 4, please, because a lot of my questions I want to raise with you, and also as I heard raised by Honorable Munya, are based on your slide number 4. Now, I'm not an actuarial scientist, but I'm trying to understand what you had been telling us, or your team had been telling us with regards to that circle. On the left, that speaks about a 0.3% surplus, and that would not be a loss, of course, so that adds not to members' reserves, and a 2.5% financial advisor and scheme expenses, and a 9.9% administration fee, and then an 87.3% healthcare claims. If I add that 9.9%, 2.5%, 0.3%, and your compulsory strict solvency regulation that complies you to have a 25% reserve, you need to explain to me whether I understand this wrongfully. Would these percentages be what is then taken from the members' contribution towards non-medical or non-benefit claims? And if I were to add that, it all comes to 37.7%. You can answer this question a little bit later. And this brings me in relation to what Honorable Munya had said about the CMS having said that 82 cents per 100 cents actually goes to claims, which is even, I think, more than what I am reading from this. If I look at the 37.7%, that leaves us essentially with 62.3% available for claims from members. But while we're on that slide, I'd like to understand what your actual administration fee is. Is it the same for all of your schemes? That's a different question. That you are providing administration to. And what are your managed care fees? And how are these fees determined when negotiating tariffs? Noting the conflict of interest issues highlighted by the Health Market Inquiry report and the cross-ownerships and directorships issues between Discovery Medical Scheme and Discovery Company. What was the percentage increase on administration over the last 2 years? And how far is that from the consumer price inflation? I hope I've not been speaking too fast for you, but I think these are very important questions that I'm hoping you'll be able to address today and maybe not put in a written reply, since you also have your CEO of your administration, of your administrator on the platform. Now, also in your slides, you mentioned the monopoly power that can put undue financial pressure on providers. Are you saying that you do not believe in active purchasing and selective contracting by the fund? And does your administrator not exercise buying power during contract negotiation with providers? And how do you manage the cross-ownership and directorship issues during such contracting? I still have 2 more questions which are based on your introduction on your solidarity that you raised right in the beginning. I just need to go to my question. I was reminded that in your introduction, you spoke about the medical scheme being in operation because of social solidarity. And I was trying to get an understanding of what exactly do you mean by social solidarity? And what are social solidarity risk pools? Is that not is it not true that this will perpetuate fragmentation? And the very last question that I want to raise with you is about out of pocket. You see, most of us on this platform, and the members especially, are members of medical schemes. And it is quite sad that when one needs service, you find that you have to have these out-of-pocket contributions. It is also true for those with a higher, what did you call it, higher class of agreement that they would have, or higher status of agreement, or the higher options. Yes, that's what I was looking. The higher options which people would have with the medical aids, they still find that they have to make such a large contribution to out-of-pocket payments. And it is quite disconcerting for one to have to do that. Now, with regards to that, what would be your view? Why is it then necessary that these large amounts of out-of-pocket need to be paid by members of the medical aids? And would that not be obliterated by the NHI fund in terms of the provision of services to people? And then on your international benchmarking, you mentioned a number of countries and your recommendation of a blended funding model. I was wondering whether you consider the limitations placed on such a model on users, including on limitation of access, and how has such a model fared in the face of a catastrophe such as was the case now with COVID-19? Would you also be able to compare other countries, or have you made an effort? Have you compared other countries such as South Korea and Vietnam that have performed better during the COVID-19 and which are actually based on a single payer dominant public health system? So those are the questions which I wanted to ask from you. I also have questions from Honorable Chirwa, who are struggling with network, and I'm going to read questions. The first question is, what was your subscription growth rates in previous years before the pandemic? Question 2, how has medical insurance impacted the scheme over the years? 3, with the growth of members in the previous year, which month saw the most subscriptions of new members? 4, how many grievance cases from your members do you have and are aware of with the CMS? And how many were resolved and how many were in your favor of the resolved cases? I think, honorable members, those are all the questions from us. We do not have, I'm not going to allow at this point, in any case, any other members to raise questions since we are at 7 minutes past 12 and we were to have finished at 10 minutes past 12. But we will allocate more time to Discovery Health medical scheme to answer these questions. I think I would give you probably another 15 minutes, maybe even 20, because so many questions were raised with you on this platform. Thank you very much. You're free to respond.
Thank you very much, Honorable Chairperson, and thanks to the members for both the comments as well as the questions. We'll try to do our best. Can I, before I make some comments, Chair, just indicate to my colleagues that I will request the Chief Executive, Dr. Reinos, to just be ready to deal with the questions that were raised at the beginning on preventative care, on the non-health expenditure, on the contracting, on your slide 4, Chair, that you raised, on the contracting, particularly the issues you raised on conflict of interest and cross directorships, and also the issue of out-of-pocket payments. I would also request Professor Harris to be ready particularly to deal with the number of questions that related to Section 33, more detailed on the blended funding model, the issue around monopsony, whether in fact the bill should be more explicit on price setting, the issues around lack of innovation, those questions. And then I would request Khalid to be ready to deal with the question that was raised at the beginning by Honorable Sengwa on Section 7. But just some comments, Chair, given the time that we have. First of all, just to indicate that on the issue around the governance, I think the approach we're taking on this is just to be very clear that we're really saying that there's clearly we have seen some serious challenges in the way we have structured governance processes in a number of institutions in the country generally. And all the plea that we're making is that there are certain recommendations that have emanated from the health market inquiry. We can look at some of the structures that are already in existence and also recall that the presidency, I know the presidency at some point instituted an investigation on how to improve the governance on SOEs. And I know this structure is slightly different from the SOEs as we know them, that is envisaged. But nonetheless, I think there are very important lessons that we are learning. So all that, the plea that we are making is, and I can say this with utter confidence because in a sense, I happen to know the current minister very well, his integrity, political and ethical. And I think we've painfully learned, and so this is not the issue around focus on anybody who exists at a particular time. I think we've painfully learned in our country that when we build governance systems, they must be robust enough to withstand all seasons. And I think that's all the plea that we are making with respect to the issue of governance. The second issue I would just like to make a comment on is that it would be unfortunate if the simplistic interpretation of our presentation is simply that Discovery opposes the NHI, because there would be nothing further from the truth than that statement. And I just hope that understanding that essentially the end objective that we are all working towards is universal health coverage. Everything else is a means towards the attainment of that objective. And I would hope that there would not be a simplification of a view that expresses some reservations around certain sections of the bill as currently constructed and be equated to basically a rejection of the bill, because we are very clear that the fund needs to be established. We're very supportive of the fact that there should be a mandated contribution to the fund. We make the point that, however, we need to make sure that the way we look at the evolution of the NHI is in a manner that ensures stability in the system as we move on, so that there are no major dislocations that undermine the very objective that we aim to achieve. That is not an argument for the existent and continued operation of the private sector as currently operating. We've made the point that we really recognize that there are many recommendations that come out of the health market inquiry that would improve the efficiency of the private sector and also make sure that there's better alignment between the private sector and the public sector in terms of towards the attainment of the objectives. And I think some of the challenges that we face may be reflected far much more, as indicated, amongst other things, of the incomplete regulatory regime. So I thought I should make those comments and maybe linked with that, Honorable Chair. The way we're looking at this is that the ultimate balance that would happen over time may well be that there would be an NHI fund that occupies a far much more dominant position. But let that be a function of a fund that grows as a function of good governance, and secondly, a fund that grows as a function of consumers exercising the choice, because everybody, we are supporting the idea of mandated contributions. We have to assume that people will act in a rational way. Nobody will want to make a contribution to the fund and simultaneously want to purchase private cover for activities covered in the fund if they are satisfied with the operation of the fund and the services provided to them. So I think that is the approach that we're taking towards this. And second and lastly, the point I would just like to make is just to make the point that when we make reference to the 212 billion, All the point that was simply trying to make is just perhaps deal with what we consider as a bit of a misconception sometimes in the discussion, and I think that reflects a belief that the money that members pay after tax to purchase and they're members of medical schemes currently automatically will be transferred to the fund. And that's the point that we're simply making. It's just to be conscious that that's going to be a very delicate process, especially because these are after-tax contributions that individually members make voluntarily. But that there should be a mandated contribution to the fund is something that we support. I'll just make those comments, Chair, and then hand over to my colleague, the Chief Executive of Discovery Health. Ryan, over to you, Ryan.
Thank you very much, Dr. Nsaluba, and thank you to Honourable Chair and Honourable members for thoughtful questions, robust debate, and a helpful conversation. I think of the list of items that Dr. Nsaluba's asked me to cover, the starting point is, in fact, Honourable Chair, your question about how the funds are broken up, dispersed. For every 100 units that members contribute to medical schemes, where does the money go? I understand your confusion that's arising there. And this is really, in the medical scheme, the difference between a balance sheet and an income statement in commercial terms. Of every 100 units or 100 Rand received by the medical scheme, as demonstrated for Discovery Health Medical Scheme in that 2019 analysis, 87 cents, just over, goes directly towards payment of healthcare providers and healthcare provider claims and medicines on behalf of the members. That should be unequivocal and clear. There are no ifs and buts. That is an audited number. It's published by the regulator. It's audited and shouldn't be questions. It's over 87 cents. It is not the 37 cents that you calculated. The confusion arising there is, where is the origin of this 25% reserves? On the income statement of the medical scheme, in other words, it's income minus its expenses, the medical scheme receives contributions from members, pays claims and other costs, and retains a small surplus, hopefully if it's priced correctly at the end of a period. That surplus must contribute towards reserves. And once the medical scheme has built up a sufficient reserve, must sustain those reserves based on the risk profile of the members in the medical scheme. So as the scheme stands today, those reserves exceed 25%, meet the statutory requirement on the balance sheet. And so in the pricing of the medical scheme, there is no specific pricing or allocation of cost towards sustaining those reserves, because the scheme is actuarially solvent. The number of claims that will be paid will be equal to or hopefully slightly lower than the amount of contributions received. And so the reserves are sustained on that basis. I hope it's clear, therefore, that of 100 Rand received by the scheme, 87 Rand in the case of DHMS is going directly to the payment of claims, and just under 10 Rand, in that example, 9.90 Rand, is going towards the payment of the administration fees. That allows me to pivot directly to Dr. Nsaluba's next topic he raised, which is specifically non-healthcare expenses, a contentious and important issue that is raised by multiple honourable members, and I'm delighted that we have the opportunity to answer that. The non-healthcare expenses average across the industry at 8% of contributions received, as reported in the Council for Medical Schemes report. If you benchmark this against healthcare systems across the world, that is an outstanding performance and represents an efficient healthcare system. The members asked the question, what is the value of these managed care fees? And in fact, one particular member asked specifically, I think it's the Honourable Member Sokacha, asked specifically, do these managed care fees not seek to just, managed care functions not seek to just reduce access to healthcare? Well, through audited and careful analysis, it is demonstrated that in the case of Discovery Health, for every 1 Rand spent on managed care investment, about R2.20 of savings accrues back to the medical scheme. In other words, the medical scheme is getting a return on its investment, a positive return in economic terms for every R1 it spends with Discovery Health's managed care capability. This is critical in any healthcare system in order to ensure that quality is optimal. Good quality leads to lower long-term cost, and in order to ensure that efficiency of delivery is optimal. In the absence of this, you get all sorts of inefficient delivery mechanisms that creep in that lead to a gross inflation, uncontrolled inflation, in fact, of the healthcare cost. These non-healthcare revenues are audited annually, are reported transparently in the Medical Schemes, Council for Medical Schemes annual report, and are visible to members and to the public. And the other question in this regard from honourable members related to the inflation and the increases. I'm delighted to answer that question and tell you that over the last 2 years, the only cost inside the medical scheme's basket of costs that has been deflationary. In fact, I think this statement goes back 8 years, and we can clarify that in the analysis. The only cost that has been deflationary, in other words, has reduced the inflationary pressure on the medical scheme, has been the cost of administration. And the specific question was, what were those increases in the last 2 years? They were approximately 0.5% to 1% below consumer price inflation. The administration increases over the last 2 years were approximately 0.5% to 1% below consumer price inflation. Clearly, that's important for us to manage, considering that wages increased by above consumer price inflation, and one needs to be able to manage this dynamic very carefully. It takes us to the very next question, which was an investment in preventative care. Can you measure in a specific metric the savings that accrue to a healthcare system as a result? And the short answer is yes. We have published these measures and metrics, and we've had them audited. In the case of the Vitality program, the Vitality program leads to savings for the medical schemes under administration through behavior change and lower risk, lower healthcare risk of the population. It's completely intuitive, of course. You can imagine a healthier population tends to claim less, or when they get ill, they have more resilience against that illness. And as a result, that protects the medical scheme against cost. So those metrics are demonstrable, are measurable, and have been published together with international commentators like the RAND Group in studies around the impact of Vitality on healthcare costs and on mortality for that matter. A very important question was asked about contracting and the basis of contracting. It takes enormous sophistication to contract with healthcare providers, and specifically in our context with the hospital groups, which represents about 40% of total expenses of a medical scheme in any period. Highly sophisticated analytics, healthcare intelligence, and data intelligence is required to measure and manage this contracting process down to the finest detail. And over years, we've invested enormously to ensure that we have not only the data environment, but also the healthcare intellectual property, the analytical intellectual property to do this. This contracting process is moving in a very consumer-centric way towards value-based contracting, where purchasers of healthcare around the world are buying a single unit of output rather than paying for the fee-for-service journey along the pathway. And this is leading to better outcomes for patients and more effective and efficient purchasing and contracting. A specific question was asked around conflicts of interest and cross-shareholding. And I should say unequivocally that there are no such conflicts of interest in the contracting process whatsoever. The regulatory environment oversees this and ensures that it's so. The architecture, as described right up front in my presentation, of medical schemes who are party to these agreements, we have totally independent boards of trustees checking that these agreements are completely robust. And in the case of Discovery, whilst there was an investment in Discovery and in a large hospital group in South Africa some 25 years ago by a single shareholder, that shareholder today is effectively diluted in the Discovery shareholding to such an extent that there are no cross-directorships and there is absolutely no conflict whatsoever in the contracting. This is subject to regulatory oversight, auditing, and the scheme's direct oversight of the contracts. One of the members asked very important points around the United Kingdom's healthcare system. Within the Discovery Group, we are the shareholder and the owner of the third largest healthcare insurer in the United Kingdom. As we sit here today, 12% of people in the United Kingdom, 12% of the population chooses private medical insurance alongside the National Healthcare Service offering. The NHS provides a broad and deep offering in the United Kingdom, but does not legislate or restrict in any way what the private sector may offer. A demand and supply environment exists that allows the private sector to offer those services where consumers choose to purchase privately, where they choose to augment what they may be able to obtain from the NHS. And in fact, as the honourable members well know, the NHS often chooses to purchase from private providers to support its own causes in the United Kingdom. It is an example of an environment where there is a single payer, single fund, working in a blended model alongside private insurers, not the blended model we're proposing. We're proposing a much more sophisticated blended model with much more collaboration, but allowing the private sector to flourish and meet consumers' needs where consumers exercise a constitutional right to elect to purchase privately. I think to end from my side, just to say, as Dr. Nsaluba has said, any narrative that labels our position as opposed to the National Health Insurance Bill is false and incorrect. We are in full support of the aspirations of the National Health Insurance Bill. We are here in front of you, honourable members, acknowledging the need for structural reform in both the private and the public sector, done simultaneously and carefully in a way that will benefit all South Africans. We support the need to improve access and equitable care. We think we have some value to suggest, and that needs a lot of additional work and debate and discussion around the technical structure of how the NHI may best be sustainable and may best achieve these goals of improved access and affordability, and at the same time reform the private healthcare sector to improve that sector too. We are not asking for nothing to change. To the contrary, we think structural shift and change is required, and we are trying to make technical suggestions based on detailed global analysis of how we can take the best of multiple markets and apply that for our distinct and specific needs here in South Africa. Dr. Nsaluba, back to you at this point.
Fine. Roseanne, over to you.
Thanks. I'll just take 2 minutes to address some of those points, and thanks for the very useful conversation. So first of all, just in terms of Section 33, the concerns that we've raised around Section 3 is firstly, I guess, definitional in terms of the fact that some of the terms in there in terms of fully implemented and not reimbursable are not defined, and that of course creates uncertainty. And as the honourable members have highlighted, when we look at Section 6 and 7 and 8 of the bill, there does seem to be uncertainty around where that role of the medical schemes would apply. And I think this leads to that question about why we don't find an international precedent with regard to a legislated limitation for private health insurance. And it's because of the gaps that are are created that then put the citizens at risk in terms of funding gaps when you have a legislated role. What we find, as Dr. Noach said in the UK, that you get this movement in terms of what the health insurance can cover based on what is working and what is not working in the public sector. And I guess moving beyond that, another way to address those gaps is actually to eliminate them by having a blended approach, which is why we are proposing a structure that certainly does not perpetuate a two-tier system at all, but rather builds on what we've seen with the vaccine program, where you have access free at the point of service and the funding happens behind the scenes, and you can access at public or private providers. Just to clarify on the misperceptions that we flagged as well in the presentation, many of these were driven by the SEAS, which is the document which provides the rationale for a number of the provisions. And I think it was Honourable Member Harvard who raised those points. I'd refer you perhaps to page 7 of the SEAS document, which provides some of those statistics which perhaps are not appropriately referenced. In terms of then the Centre for Innovation and the monopsony model, when you look at section 11 of the bill, it refers to purchasing at the lowest possible price. And of course, this could be considered at odds with the principles of value-based purchasing. But the real challenge with a monopsony purchaser comes in terms of once the decision is made, once a dominant purchaser has made the decision as to which service providers are going to be accredited, then there is no market anymore, because there is no one who is permitted to provide those services under the NHI bill. So if the appointed service providers do not perform, there is no competition for them in terms of the renewal of their contract, for example. And so the sustainability of that model without that competition is the point that we're flagging as a concern, and that in a multi-fund approach that you can have a system of managed competition, as we've seen in a number of other markets. And of course, with that competition then becomes the drive to promote innovation as well as a way to differentiate the service offering. So I think from a price setting point of view, there's a number of learnings that can be incorporated as we build on the model. Thanks, Dr. Nsluba.
Thanks very much, Rosanne, and thanks, Ryan. Chair, thanks very much again for your time and this opportunity. Time, unfortunately, is the enemy. Now we know that we appreciate the fact that you've given us some time to go slightly over the scheduled time in order to be able to respond to some of the questions. We really appreciate the engagement. And really our view is that all of us need to put our calm heads together and try to see how we can design something that will work, that advances our policy objectives. There's too much at stake. And I'm sorry, I should have also, I'll just make this comment. There's too much at stake for our country. And therefore, I think it's important, and we wish the committee well in your deliberations as you go over all the inputs. And we will avail ourselves, of course, to clarify, come back, answer any questions that you might have. I'm sorry, Chair, I forgot to also ask, and I will make no comments after that, to ask Mr. Khalid Mayet to make any comments that he would like to make on the Section 7. Sincere apologies, Chairperson. Khalid, if you can just come in, and I will not make any further comments. Thank you.
Thanks very much, and I just wanted to point out that the question raised by Honourable Hlangwa is actually quite an interesting question. It's a focus on a particular provision in the bill, which not many people have focused on in the past. But interestingly, it goes to the hub of what, in a practical way, what the NHI bill is all about, and where. And how we need to look at the NHI with a much more kind of broader kind of lens. So essentially, Section 7 deals with the question of how a user would be able to be guaranteed access to healthcare. So what it does basically is to say that well, in essence, the way the national health the bill is structured is that every user, every person in the country would be attached to a particular provider. In this case, potentially a GP, and then the kind of service delivery model cascades up from doctors to a primary care facility or to a tertiary facility. So it's built up on a model that kind of cascades upwards to the highest levels of care. And what this section particularly does is that it tries to say that in every instance where a particular provider is unable to provide a particular service, the administrators of the national of the fund need to make sure that that kind of service is provided to everybody else. So in essence, it seeks to address some of the problems of inequality and uneven distribution of healthcare resources across the country. So its objectives are very important, and it seeks to make sure that nobody is left uncovered. But the problem is that in the way in which it's structured, it's potentially too prescriptive. It sets out only a defined path in which a person or a user can access services if it's not available at a level of care closest to the person where they are located. And that's where we think that there could potentially be problems with Section 7, because it could create gaps if along the path to obtain that particular service, those particular facilities and resources are not available at all levels in a particular area. So Honorable Tlangwa, I think it's an important question. I think it will test our capability to be able to to ensure that services are available to everybody else. We are concerned that that particular section could kind of create gaps. It may not be able to address all the kind of issues, but in general, I think the intent of the clause is a good one, and hopefully in the way in which we look at collaborating with each other to try and make the national healthcare system work, that we'll be able to address some of the kind of practical problems associated with Section 7. So I think it has noble objectives. They are practical problems, but I think that those problems are capable of solution.
Thanks, Khalid. Over to you, Chairperson. Thank you very much once again.
Thank you, Dr. Saluba and your team. I think, let me apologize for having pronounced your surname wrongly. I put the B where there should be an L and vice versa. We appreciate the responses to the questions, and yes, we are running a bit out of time with regards to the allocated time to yourselves. But I would still think that yourself and Dr. Noach should really maybe write to us about the questions which I've raised, and I deliberately put it in the manner which I did, because this is also an opportunity for us as members of Parliament to understand how the medical schemes operate. And as you are aware, we also have the Council of Medical Schemes who account to us. So therefore, my question, even having been answered by Dr. Noach, I think should have some more response to it, to the question on the administration charges, about the managed care fees, about the negotiations of tariffs and the conflicts of interest between the medical scheme and the discovery company, etc. And I know that we are not afforded enough time to do that. So thank you very much again for coming today, but I am looking forward to your written response to those questions. And just as a last opportunity to you, Dr. Saluba, to say anything before we go on to the next presenters. Thank you.
No, thank you very much, Chair. Once again, just to thank you for the opportunity and again to just appreciate the engagement and undertake that to the extent that there are some questions that were not fully answered, as you indicate, we will respond to the committee in writing. Thank you very much.
Thank you very much. You are free to stay on if should you so wish, or you could leave the platform Again, we are expressing our appreciation for you coming to do this presentation before the Portfolio Committee. Honorable Van Staden, I see that your hand is raised.
Chairperson, I just want your permission for me to leave this meeting at 1. I have a doctor's appointment to attend to in Pretoria North at 1:30. Thank you, Chair.
Thank you. You're very welcome. Ms. Majulamba, I would assume that the next team is here.
Yes, Chair, they are part of the meeting. Thank you.
And who will be representing them today? Welcome. There's quite a bit of echo on your system there.
Good afternoon, Chair.
Yes, before I allow you, let me just welcome you properly. So we have the team from Polmed who will be doing a presentation to us now, honorable members. We have received this presentation and we have been able to go through it. I'm just going to tell you, I'm trying to get your full name. I just see Neop there. Maybe your full name I will get from you now. The chief presenter from Polmed, just to inform you that you have 45 minutes, which will take you to 25 minutes past 1. For your presentation, we'll have another 45 minutes for discussion. Thank you very much. You're welcome to continue.
Thank you, Chair, and good afternoon, Chair, Honorable Chair, and good afternoon, honorable members and my colleagues. I'm Lieutenant General Quina, a Polmed Board of Trustees member. Firstly, Honorable Chair, I would like to make an apology for the chairperson of Polmed Board of Trustees us today. With us in this meeting, Honorable Chair and members, Deputy Polmed Board of Trustees, Mr. Tilani Ngwenya.
Lieutenant General Quena, we cannot hear you so clearly. Sorry for interjecting now. I'm not also certain whether it is on my side or your side. Let me just ask the honorable members quickly. Am I audible, honorable members?
Yes, Chairperson, you are, but the presenter is not.
So, Lieutenant General Quena, could you maybe look at your system there before you continue? Thank you.
Okay, Honorable Chair.
That's much better. Thank you.
Okay. Thank you, Honorable Chair. As I've indicated, I'm Lieutenant General Quena, who is going to present together with the Principal Officer, Ms. Neo Kaue, and the Chief Operation Officer, Dr. Making. I must just indicate that the chairperson of the Polmed Board of Trustees, Lieutenant General Vuma, is not with us today. She was supposed to be here, but unfortunately she couldn't be here. With us here in this meeting from the Board of Trustees, we've got the Deputy Chair of Polmed Board of Trustees, Mr. Tulani Ngwenya, who's also the Chief National Negotiator for POP Group. We've got Pitan Zime, the Acting Deputy General Secretary of SAPU, who's the Polmed Trustee member. We've got Mrs. Neo Kaue, who's the Principal Officer. We've got Dr. Making, who's the Chief Operation Officer of Polmed. We've got Ms. Vuyo Kaka, the Executive Legal Compliance and Scheme Secretary. Mr. Martinez Pretorius, the Executive Finance and Procurement. Ms. Puti Maboja, the Provincial Treasurer of POPU from Limpopo, who's also a board member. We also have Ms. Ntombifuti Manyoni, the Chief of Staff for Polmed, and as well as other Polmed members who logged on later on. As I've indicated, it will be myself doing a partial presentation accompanied by the Principal Officer, Ms. Neo Kaue, as well as the Chief Operation Officer, Dr. Making. Can you go to the first slide, please? Honorable Chair and members, go back. The first slide is talking to the contents. Firstly, we are going to start with the background, the context, the purpose and commentary, demographics, Polmed health requirements, unique offerings, lesson learned from COVID-19, exemption request, then we'll come to the conclusion. As I've indicated, we'll start with the context to indicate that the South African Police Service medical scheme, it's a closed or restricted scheme registered with the Council for Medical Schemes in terms of the Medical Schemes Act, that is Act 131 of 1998. And only the employees of the South African Police Service, that is both active, retired, as well as those who are medically boarded, who have been appointed in terms of the South African Police Service Act, that is Act 68 of 1995, as amended, are eligible to join as members of the scheme. The scheme offers two benefits in terms of option. Then well-known aquarium, that is offering the basic cost-effective benefits aimed at the young and healthy, as well as the marine offering, which is talking to also basic and enhanced benefits for older and sickly members. In terms of membership, Polmed has about 172,940 members with 492,259 beneficiaries. Can you go to the next slide? Now, the nature of the work done by members of the SAPS and also the risk attached thereto are also consistent with members in the National Defense Force, as well as the members of the State Security Agency, SSA. In particular, we are focusing on the provision of Section 199 of the Constitution of the country, which provides that the security service of the Republic consists of a single defense force, a single police service, and any intelligence service established in terms of the Constitution. Now, without further elaborating on Section 199, and in the interest of brevity, it suffices to draw the attention of the committee to Section 199 until Section 210 of the Constitution, read with Section 17 and 24 of the SAPS Act, and Regulation 30 and 31 of the regulations issued under the SAPS Act. Next slide. Now, this set out the commensurate purport and equating of the Defense Force, National Intelligence, and the Police Service, and all the provisions for the distinguishing of the civilian service from the core of the functions. There can be no better and more comprehensive articulation on why the SAP should be part of the excluded military health service and other establishment, namely the SSA, from the application of the NHI bill. Now, it's our considered view that members to whom the NHI bill is not intended to apply should include members of the SAPS. The nature of the work done by members of the SAPS and the risk attended are consistent with those envisioned in the South African National Defense Force, as well as the SSA. Now, policing is a physiological and psychological stressful occupation filled with danger, high demands, human misery, and exposure to trauma and death. Research undertaken has identified connections between the daily stresses of the police work and higher risk of long-term physical and mental health effects. It is accepted that there are health disparities between the police officers and the general population. Now, in this instance, as I've indicated, Honorable Chair, we proceed with this, the context to say that, quoting the support letters from the acting National Commissioner, Lieutenant General Patlani, which was an annexure to our written submission in November 2019, in a policing context, the management of moral hazard as envisaged in the NHI could have severe unintended consequences for policing and the way that the services are provided to the public. The provision of health-related service or benefits to such member far exceeds the provision allowed for in the current MSA and the prescribed minimum benefit. Polmed has over time collected significant clinical data in order to better understand its members' unique profile and responded by developing disease management programs that are member-centric and aim to improve the health outcome of its members. These programs require innovative benefit design solutions and simple yet effective delivery techniques to manage underlying conditions. In this instance, Honorable Chair and members, I'm going to hand over to our Principal Officer, Ms. Neo Kauwe, to proceed with the presentation. Thank you. Ms. Neo Kauwe, with your permission, Honorable Chair.
Thank you, General Kwena, and thank you, Chair and honorable members. We actually note the purpose of the bill, Chair, as set out in the preamble. In particular, the preamble sets out the following as the intention of the legislature in enabling the NHI bill: to achieve the progressive realization of the right of access to quality personal health care services. That's in section 27 of the Constitution. To make progress towards achieving universal health coverage. To ensure financial protection from the costs of health care and provides access to quality health care services by pooling public revenue in order to actively and strategically purchase healthcare services based on principles of universality and social solidarity. Further, to create a single framework throughout the Republic, which is equitable, also appropriate, efficient, and effective public funding for the purchasing of healthcare services and the procurement of medicine, health goods, and health-related products from service providers within the context of the national health system. And lastly, to ensure continuity and portability of financing and services throughout the Republic. We, Chair, are actually saying the national values underpinning the above set of intention can only be commended. Basically, we are agreeing with all these principles. However, following, we're just going to give you a brief background on who Polmed is, what Polmed has covered its members on, and we will also then just give you some of the reasons why we believe that Polmed should really stay as it is. It is therefore for this reason that we wish to open our submission, Chair, with an emphatic resonance with the intentions enumerated herein above. I'm going to ask the COO, Chair, with your permission, Dr. McKing, to just cover the next few slides, then I'll take over from him thereafter.
Thank you, Pio, and good afternoon, honorable members. The slide in front of you just highlights the demographics of the scheme. It's divided into marine plan and then aquarium plan. Marine plan is the higher plan, previously called the higher plan, the more extensive benefits, versus the aquarium plan, which is the more cost-effective with the prescribed minimum benefit level of care. So the 172,910 is divided into the principal members, 114, just over 114,000 marine versus just over 58,000 for aquarium plan. Beneficiary-wise, 300,000 versus 185,000 on aquarium plan. There's the female-male distribution, average family size, and then chronic ratio also highlight there. 10% for a marine plan versus 31% on aquarium plan. Go to the next slide. The biggest cost driver for Polmed, if we look at disease demographics, is mental health disorders. It goes without saying that due to the extreme working conditions the SAPS employees work under, mental health is indeed the biggest cost driver. And as you can expect, most of our attention and focus is driven to manage the mental health disorders. We want to focus on 3 of those diseases. You'll see we've listed 5 because it's part of the prescribed minimum benefits. Bipolar and schizophrenia, although it is included in the prescribed minimum benefits, because it's generally genetically driven and not necessarily work-related, we want to provide a little bit more details on depression, post-traumatic stress, and then also attempted suicides. On the top line there of importance is the report that has been looking at the prevalence, the report that has been generated by the health quality assessment, which look at over 80% of the private medical aid industry claims. Most medical aids in the country participate in the health quality assessment reports, and it's for this reason that we just want to highlight those figures there. If we look at the 2015 information, you'll note that just over 10% of the Polmed population were registered on depression versus industry of 5.1% in 2015. Compare that information to the latest data in 2020. There you'll see 2.7% of the Polmed population have been registered as depression sufferers versus industry of 2.5, and we'll elaborate why those figures are so important. If we go lower, post-traumatic stress can be linked directly to the work environment. 600 members have been registered in 2021. Attempted suicides, 3 in 2021. So the tailored benefits that Polmed has offered its members, as is summarized there in that big column. We have debriefing sessions, which is payable from risk. It is a national instruction from the National Commissioner that within 24 hours, maximum 48 hours after a major traumatic incident, all SAPS employees must be debriefed. And for that reason, Polmed has contracted private psychologists as well as social workers to assist with the debriefing. We pay those debriefing sessions from risk and not the members' out of hospital benefits. Furthermore, we have a holistic member management at the point of discharge from hospital. We want to move away, and we've actually focused the last few years from a lesser hospice-centric management to a more out of hospital management, where at the point of discharge, we want to engage the member and various service providers with a comprehensive care plan so that members can be seen within 7 days after discharge in order to avoid readmissions. And also, we're glad to report that Polmed has been the scheme with the lowest readmission rate within 30 days after discharge. And this, for this simple reason, that we refer people to psychiatric and GP follow-ups immediately after being discharged. The impact of these tailored benefits that we have implemented is summarized in the last column. There is, we have a very effective disease risk management program, which has actually reduced, considering the extreme working conditions that the police force are working under. The prevalence of registered depression patients have reduced from 10% in 2015 to 2%, just over 2% in 2020, compared to the industry 5% in 2015 compared to 2.7% in 2020. And that result is predominantly driven by effective programs whereby it's not that the people are not exposed to severe conditions. However, by effective management, the patients have been avoided to be registered on depression and chronic medication. Furthermore, we have the lowest condition-specific mental health readmission rate as per the 2020 Health Quality Assessment Report. And as I indicated earlier, that is predominantly driven by the immediate referral to GP, psychologists, and psychiatric management post-discharge in order to avoid readmissions. The attempted suicide, although we're not providing all the figures, I mean, has remained stable for the last 5 years in the Polmed environment. Let's go to the next slide. The next disease that we just wanted to highlight and put some focus on is HIV. Prevalence in the industry, and we just want to highlight to the committee that although we're not providing all the detailed numbers, we just want to provide a picture to the honorable members just to get a ballpark figure of what we're dealing with in terms of prevalence. Polmed's figures around about 6.1% and versus industry of 3.6%. of HIV. If we look at the tailored benefits that we provide our members, and this is also indicative, which must be taken into consideration in terms of overall patient management of these diseases. Polmed's prevalence is almost double that of the industry, although we have provided, or however, we have provided proper disease risk management programs where the services are funded from risk instead of out of hospital benefits, and we are also monitoring the ARV, the antiretroviral compliance very, very effectively. The impact of these programs are as follows: that the viral load of Polmed compared to the industry in terms of measurement, 93% versus 88%. And then also if we look at the hospital admissions, specifically for HIV-related complications, for Polmed it is 0.65% versus the industry of 1.32%. Now, if you consider that Polmed's prevalence is almost double that of the industry versus the hospital admission rates, which is half of that, there's almost a fourfold improvement in lowering hospital admissions in Polmed, demonstrating effective out-of-hospital management of our patients. But the next one. COVID-19 also, we would just like to highlight a few points here, is that Polmed's prevalence, and that the number that you have there is Polmed, that we have funded that are registered via the PCR testing, 12%. The 0.1% is not the private industry, but taking into consideration private as well as the non-private industry. We had access to this information via our health actuaries. If we look at the tailored benefits that Polmed has introduced to our members, considering that in 2020, March 2020, when the bomb really hit the industry as a whole, Polmed, really did not have time to self-isolate. Our members were out in the field continuously, and our management team was with our managed care were supportive of the police service throughout the pandemic. We've conducted the PCR testing long before the PCR were compulsory and part of the prescribed minimum benefit level. We provided the services to our members at all roadblocks throughout the country. The PCR tests were funded from risk and not out of hospital, and that was also introduced before the PMB level of care. Personal protective equipment was also provided to medical practitioners and hospitals, ambulance staff, also before it became compulsory. We introduced the virtual consultations during the lockdown. I believe most medical aids did that. We also did an extensive on-site vaccination rollout in collaboration with the National Department of Health and the SAPS Employee Health and Wellness Program. That was an extensive process and program that we introduced with excellent results. We had vaccinated just over 80,000 SAPS employees at the various SAPS sites, and we conducted that over a two and a half month period. We also provided a 5-month multivitamin provision to the highest at risk individuals. I believe it was just over 179,000 individuals received those multivitamins in order to optimize their immune systems during the pandemic. We also provided isolation support to 284 individuals nationwide that could not support themselves in terms of self-isolation after being infected. We also monitor our daily statistics of COVID-19 on a daily basis, be that tests that were conducted, new infections, as well as the death rate are closely monitored and liaised in close collaboration with the SAPS steering committee on COVID-19. The impact that we have seen with all of these efforts that we have introduced is that Polmed has got a very, very low morbidity rate, in actual fact 0.3% overall. The screening services that we conducted at the various roadblocks since, at the launch of this project, we identified 72 individuals that were at the time of conducting the tests were symptom-free. However, they mingled amongst their staff. And immediately we could have isolated those members and protected further downstream infections that would have occurred had we not isolated them with this early detection. Furthermore, 68% of the SAPS, of the Polmed beneficiaries that tested positive compared to 0.7% of the national population. And the reason why that number is so important is that it is paramount in patient management, not just in South Africa, but worldwide, that testing, PCR testing, being the mainstay of diagnosing people with COVID-19 in order to protect downstream complications, with 68% versus 0.7% in the national population, demonstrates the commitment that the Polmed team has in order to identify early identification of Polmed. So I'm going to hand you over back to the principal officer to highlight further points.
Thank you, Dr. McKing. Polmed has unique circumstances. We've highlighted briefly, Chair, some of the main challenges that SAPS members who are Polmed members are faced with. We could, in the interest of time, Chair, we tried to summarize some of these issues because we could take, in fact, the whole of your day just presenting these nuances that we are seeing at Polmed. So we're trying to indicate to the committee some unique offering that Polmed actually has. We also have issues and challenges with burden of diseases. Our members are exposed to hyperlipidemia. We have cardiac and renal failure issues, diabetes, etc., etc. We haven't really focused on those yet, Chair, but we just need to summarize to you what are some of the unique offerings that we have. We try by all means to have member-centric benefits that are based on member needs analysis. So what does that mean? We target and we improve overall healthcare status of SAPS members by on an annual basis when we do benefit design. We focus on specific challenges every year because introducing some of these disease risk management at a go might not yield intended results. So in 2022, we have introduced weight loss program for specifically those members who have issues and challenges with weight. We will, as a scheme, identify those members in collaboration with SAPS, obviously, because they have all the data, including the health risk manager in SAPS. By so saying, we also indicate to you, Chair, that the fragmentation that was there previously is no longer there because Polmed, SAPS, and all other service providers that are providing health service to SAPS members, we collaborate and we talk to each other. We also now try to get members to cease smoking by providing a specific program that will address this specific challenge. And because our members are exposed to trauma, consequences of that is that there is prolonged illness or challenges. To that extent, we have a prolonged care or a home-based care services that we render to these members. These are as a result as well, Chair, that our members are exposed to high incidence of trauma, MVAs, injury on duties, and et cetera, et cetera. Some of these funds we can recover from RAF and IOD, but in most instances, Polmed is providing this extended service to its members, and we use our pool of resources that we have, limited as they are, to actually make sure that our members are taken care of. Our ex gratia policy as well is helping those members who, for instance, earlier in previous conversation, Chair, just to address that, out of pocket and members not having access, that is limited at Polmed because Polmed also has got some ex gratia pool where we assist our members. The second thing is that we have extensive managed care programs to address mental health disorders. We've briefly indicated to you that that's one of the major challenges that we have. The debriefing sessions are payable from risk, meaning that our members have got enough funds for day-to-day benefit. We also look at a holistic member management at a point of discharge from hospital, meaning when a member is discharged from hospital, there is a plan to assist that member out of hospital. Hence, you saw what Dr. McKing has indicated, that we have less readmission rate. Once we have identified a member and we've treated a member, we make sure that that member doesn't get repeatedly hospitalized, meaning there's quality of life for these members. And because of Polmed's interventions, SAPS has more active members on duty than members actually at home sick, not being able to go to work. We also have lowest condition-specific mental health readmission, like I've already indicated. We are not saying that ourselves. HQA is indicating it in its report. That report is available to the industry. Anybody can look at it. We are actually not indicating these ourselves. It's somebody else who've assessed us amongst our peers in the industry, and it is confirmed that there is low readmission rate. As time went on, Chair, we actually needed to understand, because there's this issue of medical aids not doing this, medical aid not doing that. We all know medical aid is a grudge purchase. We wanted to see how relevant Polmed was. We conducted an independent study around 2019 to check whether Polmed is actually effective or not. Those results, using signal model by the provider that assessed us, they indicated to us that we are the most cost-effective medical aid in the country. Having said that, what have we learned out of COVID that we are bringing to you as a committee for you to note? The screening and testing that we did at operational sites during lockdown that attended to 14,136 members that we tested then, did not just end at those members. When we get to a roadblock, we don't just find SAPS members. There are Metro Police or the traffic police, and there are soldiers. So Polmed didn't just assist SAPS members. We also gave care to those members who were assisting the police at different roadblocks or at different platforms. Those statistics we didn't really cover here, because at that moment in time, we did not want to get to a roadblock and exclude other members. If it meant screening at a roadblock, we screened everybody who was there. If it meant that we picked up some issues or challenges with any member at that specific roadblock or customer service center, we then referred those members accordingly, and their different schemes would then take care of those. But Polmed did spend some money in those members, and it is indicative that the security cluster, when looked at from a holistic approach, it becomes evident, and it becomes even more relevant for this committee to note the reasons we are requesting us to be classified as well, or to actually implement what the Constitution says. It's important. It's very important. We actually the leading scheme in collaborating with Department of Health. It is in the room. It can confirm that Polmed was one of those employer groups, if not first of the employer groups, to approach DOH to request that we vaccinate our own members, given the fact that the department had to look at the country in general. We then took responsibility of our own members. We proposed that we vaccinate our members at the respective SAPS site. We made inputs as to how that could be done, circumventing the issues and challenges or the requirement of registration on EVDS. Thank you to NDOH. They were open to our approach and our suggestion, and it was possible for us to vaccinate our members at work. What they did was also to show us that those that worked with SAPS members, from traffic police, IPID, everybody else was actually willing to be vaccinated at these sites. But because of some of the challenges that I've already raised, we couldn't vaccinate those members. And because our vaccination period was specific and we had issues and challenges of expiry of the vaccine, we could only do the number that we are highlighting now. Otherwise, if we had enough time, we would do say to this committee, we would have actually vaccinated more of our members and assisted as well in vaccinating the other groups of the security cluster. So Polmed didn't just end there. Again, because there was another issue challenge in providing certain of these, and we were willing to assist our members at any given time. We actually provided isolation and quarantine sites to all our members nationally. We still are providing these as we speak, Chair. And like Dr. McKing has already highlighted, we provided our members with a multivitamin to boost their immune system. So these extended benefits that are in excess of PMB level of care on the marine option, because as you've seen earlier, marine option is one of our biggest option, meaning that we actually take care of the bulk of our members through marine plan by actually giving them more benefits, and we don't leave aquarium outside. Like I've indicated already, we have a ex gratia program that addresses all the shortages and issues and challenges that members have. We believe that these lessons that we learned from COVID taught us that agility is very key. There was no time for us not to stand and act with immediate effect. And the partnerships that we've had with SAPS, DOH, enabled us to be at the fore, right, of supporting and providing service to SAPS members during the uncertainty and within the limited times that we had to operate under. By requesting what we are requesting, Chair, we don't want to drop the synergies that we've already built with SAPS EHW and SAPS Health Risk Manager. And it becomes even easier for us to link up with a Department of Health where it is necessary. So it's very important that this specific point should be borne in mind. And we really had enhanced focus on preventive measures. And at this point, member education was very key because nobody knew what COVID was. We didn't understand what we expect. We didn't know what to do. But because of our expertise, we could provide support to our members. We could provide support to the employer, SAPS itself. We could provide support to even service providers that needed or required to provide service to our members. So it was actually a huge success for us and our members during the pandemic. So we are actually asking, why should Polmed not be included in the NHI? We've stated some of the reasons, but let's just get specific focus. We are saying due to the unique nature of working conditions of SAPS, the SNDF, and the national intelligence, as outlined in Section 199 of the Constitution, the above mentioned categories have been included in the security cluster of services. So we are actually just alerting the committee that SAPS should also be considered for that. We're saying based on the nature and the risk exposure of the employees of the security cluster, there is a prerequisite and in the interest of national security that members of the security cluster have access to medical services as and when it is required. Chair, in the previous presentation, there was focus on Section 7 that specifically draws our attention to how services will be accessed in the NHI space. So we believe that these members, as grouped by the Constitution, there will be serious national security if they are expected perhaps to go through the scheduling, to go through the allocations as envisaged, and to even wait for medical care at that specific point, as opposed to them accessing medical care as and when it is required. And we are also seeing COVID experience has actually demonstrated how important it is for SAPS members to have access to medical services without any delays and the agility required by the scheme to actually provide those services, we have outlined some of the issues and challenges that we could avert as a result of us as the scheme being agile in addressing our members' challenges. Polmed members mental health support program that has been demonstrated to be very effective, Chair, that provides unique services to its members, gives us another reason why we shouldn't allow SAPS members to experience the other processes that the members in the population would follow, because all these benefits that has been realized by this program will be lost. We've had issues and challenges where members aren't willing to join the program because obviously there are challenges in the employer space that precludes them from willingly joining the program, but because of the confidentiality that has been afforded to our members by Polmed, members actually willing to partake and participate, and it has proven that our members are improving from this specific issue. The synergies, Chair, of the interaction, I've already mentioned that we will not afford not to have those synergies in the NHI space. The preventive screening benefits that are provided to SAPS members via our wellness days, these we conduct at employer side. We go to actual police stations or clusters or forums or where there are events. That's where we provide the health days. These health days assist us to gather data on our members. Then we know what preventive treatment should we give to our members, or what treatment should we give to our members before they actually complicate. Example, when members hop onto SAPS, we screen them at that level. We pick up conditions while they start working, if there are any, and we can treat them from day one when they join the force. So the mental health benefits, Chair, I've indicated that it is imperative that we don't lose the already established program that takes care of SAPS members. In conclusion, Chair, I don't have a lot to say other than Polmed supports the NHI, and we understand the rationale and the access it will provide to all South Africans. We have presented to the committee the uniqueness of the SAPS member base and the agility required to care for our member profile. Lessons learned from COVID has taught the scheme that SAPS members ought to be reclassified and their medical needs cannot be compared to those of ordinary citizens. We've submitted detailed submissions in November of 2019, together with letters of support from the then acting SAPS National Commissioner, Lieutenant General J.K. Pahlani, as well as the current SAPS National Commissioner General KJ Sitole. The main focus of today's presentation, Chair, was just to put emphasis on and seek audience from the committee for you to understand and reconsider the reclassification of SAPS under the security cluster. Thank you so much, Chair. Over to you, General Kwena.
Thank you, Principal Officer. Thank you, Chair. That was the presentation from Polmed. We are ready to take questions. So back over to you, Chairperson. Thank you.
Thank you very much, General Kwena and your team. We appreciate you coming to do this presentation to the Portfolio Committee today. We have a number of members who want to raise some questions to you. I'm going to name them in order. It will be Honorables Ismail, Sukacha, Howard, Clark, Flengwa, Hela, Chirwa, Munyai. I'm going to repeat this order. It's Ismail, Sukacha, Howard, Clark, Flengwa, Gela, Chirwa, and Munyai. Please, honorable members, you may continue to raise your questions of clarity or any other questions with the presenters. Thank you.
Thank you, Chair. Good afternoon, and good afternoon to everybody else on the panel. I just want to say thank you for the presentation. And while we appreciate the work of SEPs and their services to the country, I just have some clarity-seeking questions. So in your presentation, you stated on why should Polmed not be included in the NHI. My questions, number one, I note you stated that Polmed provides wellness days, which is unique. Now, I know of other medical schemes like Key Health as an example that also provides, wellness days to its members to assist with the risk management programs, as each workplace, has its own set of health and stress risks. Now, the NHI, is meant to provide a universal healthcare system to the country. Would this then not be unfair to other workers and citizens of this country? Also considering that, if a policeman is, obviously contracted to Polmed and his family as well, the family members are also going to be receiving special treatment under Polmed if, this is allowed under the NHI. And my second question for clarity is that, do you feel that the NHI will not be providing effective healthcare services to the country, and that is why you're requesting that it be not included in the NHI? Thank you, Chair.
Thank you very much, Chairperson. Let me also welcome the presentation. Just three questions from my side, Chairperson. The first one is, unlike the South African National Defence Force, the South African Police Service does not have their own hospitals and sick bays. What are you proposing in terms of service delivery platform? That is my first question. My second one is, the NHI does not recognize healthcare as an industry, but as a service to all. Does Polmed see healthcare as an industry? Then my last question, Honorable Chairperson, is why is Polmed questioning the comprehensiveness of the benefits that are going to be covered under the NHI? Why are you not confident that the benefits such as weight loss that you are currently offering to members of SAPS will not be covered under the National Health Insurance? Why are you questioning that weight loss will not be covered under the NHI? Thank you very much, Chair.
Thank you, Chair, and also thank you, presenter. I have two questions. First one, in your statistics, as shown in slides 11 to 13, does this also apply to CVD member of the SAPS? What is your proposal on coverage of CVD members of SAPS? Second question, has the SAPS presented their proposal to the JCPS cluster of government? If so, what is their outlook towards what is being processed? Thank you, Chair.
Thank you, Chairperson. Thank you. I would like to just ask the following two questions, and these questions have been elaborated in some retrospect by my colleague, Member Ismail. One, policing is an extremely tough job and has major consequences on the mental health of police officers. Keeping this in mind, in what ways does the bill cover mental health needs and services? The NHI intends to improve access to healthcare services. You mentioned that Polmed should be excluded from the NHI as SAPS members would not SAPS members would need access to healthcare without delays. In your view, do you feel that the NHI will result in delayed access to healthcare? What consequences would such delays have on the mental health of its members? I thank you.
Thank you, Chairperson. First of all, let me welcome the presentation from Polmed. I have only one seeking clarity question. There is a statement that said the synergistic interaction between Polmed and SAPS employees' health and wellness will be lost in the NHI bill implementation. Could you please expand on this finding? Thank you.
Thank you very much, Chairperson. Let me also welcome the presentation from Polmed. I've got a few questions that I want to ask. We note Polmed's support for the NHI. Danko for that, we really appreciate. Has Polmed or the SAPS conducted benchmarking of how police services in other similar jurisdictions are provided for with regards to the healthcare coverage? My second question, what are you proposing in terms of coverage for extended family of members of the SAPS? My last question, Honorable Chair. Section 3.2 of the bill provides a guidance on the proposed applications of the provisions of the NHI bill in relation to their applicability to the National Defence Force and State Security Agency. Based on Polmed's, are your inputs aimed at recommending that this section of the bill should be amended? If the response is yes, what specific amendments is Polmed hoping for? Thank you very much, Chairperson.
Thank you very much, Chairperson. My questions to Polmed is I want to know what their growth rate has been over the previous years before the pandemic and in comparison to January 2020 and going on forth in the past 2 years. And secondly, I also want to know how the introduction of medical insurance has impacted the scheme over the years. And thirdly, I want to know how many grievance cases they have from their members reported to the CMS, and a percentage of how many of the resolved cases were done in their favor as a medical aid scheme. And number 4, I want to know how easy it is for their members to get on PrEP, because we've noted that it is a challenge for many members on medical aid schemes to get on PrEP, which raises a very, crucial question on the issue of primary health care. And if the presentation of medical aid schemes as an alternative for primary health care and things like PrEP are not easily accessible. So if they can just divulge the process of members getting on PrEP and how easy it is for their members to get on PrEP. And number 5, I want to ask about how they charge or cover speech and occupational therapy services, if they fall under, general savings of the medical aid scheme, or they fall under specialist services. Because I also know that this varies, but if they fall under savings, like in other medical aids, then it impacts members negatively because these are consistent needs. If a member requires any of these speech or occupational therapy, whether from a stroke or whatever, then it disadvantages the member or the patient if it is charged under savings. So just give us clarity on that part, and also just make a brief comment on what I'm saying, if it is the case as well, with Polmed. And lastly, I want to know how exactly you deem the NHI will compromise your members, and then in relation to that, what then do you deem as an inclusive healthcare system, if the NHI isn't necessarily ideal for your members? Thank you very much, Chairperson.
Honorable Munyai.
Hello, Honorable Chair. My first question is as follows. Has the membership of Polmed been increasing? That is the first question. Can I be clarified why this motivation has been presented by Polmed, not department, as neutral body that does not have a vested interest? Then I must also ask the following, Honorable Chair. I want to understand whether Polmed can, whether the presenter can clarify how the proposal should address other security services, such as a Metro Police and other police services. Lastly, it's not last, but it's the second last, first last, the Polmed presentation has in more ways than one made comments that suggests under NHI, Polmed members will not receive the proper health care that deserve, and the NHI will not be capable of addressing the healthcare challenges experienced by Polmed unless they are taken care of by Polmed themselves. May I get some clarity on this motion if I understood you correctly, particularly in as of for the basis are concerned. I want to know whether Parliament support national health insurance bill content, and do they believe we should continue with racial two-tier systems in which medical aid schemes benefit almost 8% of relative to GDP, which account for over 400 billion rand. Is this that what they think we should continue with the status quo, or we should really change the current status quo, which in my view could help us to achieve universal health coverage, and the vehicle to that universal health coverage should be the national health insurance. What is their view?
Thank you very much, honorable members. Any other member who wants to raise any questions at this time? Anybody I had missed?
Okay, just one thing. Is Polmed aware the role of the complementary role of the medical aid schemes that will be played under the NHI? Because the NHI really in some section indicate that the medical aid schemes will play the complementary role, because it doesn't say that medical aid, they'll be regulated, so to speak, and play a critical complementary role. What is their view?
Thank you very much. My points I want to raise is with regards to your reasons for advancing that Polmed should be retained in its current form. And so I want to raise a few points with regards to that, whether your motivation has more to do with general societal challenges, or are these specific to the policing community, and whether you would think that if your motivation is to be considered, and noting that NHI will be funded through taxes, you should make a suggestion as to how you propose the SAP should be treated. And if SAPs has to be treated in this way, should we say we should make the same exclusion for others like the healthcare workers, the educators or the education sector? And are you proposing that SAP's members must be exempted from paying NHI specific taxes? And then we've heard you speaking about the vaccine rollout for SAP's members. It does seem like it was not an easy task to be done. And your medical aid as Polmed does not deliver services, you buy services from service providers. Would it then mean that Polmed's proposal and the model that you are proposing would be duplication? And I also want to ask you about your the model that you proposed and the comments which you made under the NHI, whether your Polmed members you think would not receive proper health care under the NHI, and whether the NHI will not be able to address the healthcare needs and challenges of Polmed's members. And then very lastly, would your members be prepared to get the healthcare services from, for example, the Defence Force, since you're relating that your situation is the same as that of the SANDF, rather than using the general health services provided in our country? Thank you very much. I think to now, those are the questions which I wanted to raise with you. Thank you. You are free to respond. And honorable members, we are behind schedule. Just to remind you that we were to have finished earlier, we're now probably about an hour behind. We will have to make up some time. If I look at it now being 19 minutes to 2, let's say Polmed finishes with the responses by 2 o'clock, we would probably be going until 15:30 or maybe even 15:45. If Polmed takes longer, we might go even a little bit longer. So let us be mindful of that. Thank you very much. General Kwena, you and your team, please respond to these questions. Thank you.
Thank you, Honorable Chair. The response will be sponsored by myself, the principal officer, as well as the chief operations officer. I would like to start from the few last, it's not the last, but the few last before the last question, where the question was whether Polmed members have increased. As we indicated in the presentation, Honorable Chair, that...
Honorable Chair.
Honorable Munyai.
I don't want to make your work extremely difficult, Honorable Chair. You know what? I realize that I miss very important question. I hope I don't derail the presenters. It's just a short question. If you allow, I can do it so that I don't disrupt the proceedings.
You may, Honorable Munyai, it's just one question, please. Thank you.
One. Thank you very much. who is administering, who is the administrator or administering the Polmed, and what are they proposing? The proposition should administrator of Polmed in the future NHI dispensation will be. I'm raising this to get a sense. What is the relationship between the administrator and the type of overheads is Polmed incurring in the current dispensation? Just that one, Honorable Chair.
Thank you very much. Please continue with the responses. You may lower your hand also, Honorable Munyai.
Thank you, Honorable Chair. As I've indicated, it will be myself, Dr. McKing, and the Principal Officer, Ms. Nell Howe, will respond to the questions raised by honorable members. One of the questions that was asked was whether members of Polmed have increased. I think the response to that was also captured when we indicated that for only SAPS members employed in terms of the SAPS Act qualify to be Polmed members, meaning if there are intakes of SAPS members, it means new members for the SAPS, new members for the scheme. We know that for the past 2-3 years, there haven't been new intakes, which means that there's no increase of members insofar as SAPS is concerned, and similarly, there will not be an increase of members insofar as Polmed is concerned. So the answer to that, there's no increase, the answer is no. Now, the other question was that why it's the members currently who are here presenting and not the department presenting. Honorable Member and Honorable Chair, the fact is that Polmed is working through the board. We indicated that the department itself presented through the letter signed by the former acting National Commissioner, Lieutenant General KJ Pahlani, and also by the current National Commissioner, Commissioner Lieutenant General Sitole, who signed that letter making a case for SAPS not to be included in the NHI. Another question, the Honorable Chair, that was raised was, would it not be unfair to exclude others? As Polmed members, we looked into the fact that since that the South African Defence Force is excluded, also the State Security Agency, who are in essence performing an essential service. SAPS also is along that bracket that is performing an essential service. That is why we are advancing the position that it should be excluded, and we don't feel that it will be unfair insofar as that is concerned. The other question that I would like also to respond to was, has SAPS taken the proposal to the JCPS? It must be indicated there's been continuous discussion even in the JCPS about the NHI, where SAPS also made its position before ultimately escalating the case for SAPS to the relevant ministry to say, let SAPS be excluded insofar as the NHI is concerned. I'm going to allow Ms. Kaue to proceed with the response to some of the questions, and also Dr. McKing, with your permission, Honorable Chair. Thank you, Ms. Kaue.
Thank you, honorable members. I'm going to start with complaints to the Council for Medical Schemes. Over the last 3 years, the statistics can be summarized as follows. 2019, 105 complaints were raised to the Council, and the Council has not overruled one of the decisions in that year. 2020, 61 complaints. The CMS overruled 2 funding decisions of the scheme. However, Polmed has lodged an appeal against one of those rulings, and the outcome is still pending. In 2021, 47 complaints, and the CMS has not overruled one funding decision during, on any one of those complaints. Just to elaborate on the membership issue that General Kwena elaborated on, clearly the last 2 years there were no intakes of new SAPS recruits, and the membership of Polmed actually overall reduced from a figure of 176,981 in December of 2019. It has reduced to 172,849 in December of 2021. So in actual fact, it has reduced.
Thank you, Dr. Makin. Chair, I'll address the bulk of the questions, some of which were repeating themselves. Polmed is by no means indicating that NHI will be substandard. Hence, our approach said we focused on the issues and challenges that Polmed members have experienced. We continue to do data analytics and assessment on these challenges. And the reason we brought in lessons learned during COVID was specifically just to bring to the attention of the committee some of the challenges that the country was faced with, where police, as part of the population in South Africa during the pandemic, had to also go through. The first example that I'll make is the PCR testing. Chair, I recall one time when SAPS in the Western Cape had police members who came from different parts of South Africa because they were there to perform specific functions. And they now had to go back to their places of residence and places of work. It was around 1 a.m. when one of the leaders in the Western Cape, after releasing those members, realized that we are right in the middle of the pandemic. These employees of SAPS are sent back. There's one component that hadn't happened. We haven't tested these members so that in an event that some of them are positive, we as SAPS could isolate them immediately or send them to isolation sites. It is at that time when we started working on devising means to get those members tested. Those members were returned back to the province of origin. At that time, Western Cape had higher numbers of prevalence of COVID, so it was obvious that there could be a chance that some of our members were positive. Polmed and SAPS had to put their heads together, and we had to set up an emergency provider to assist us to test those members before they could go back to their respective areas and go back to work. If those members had to go back to the Western Cape to stay in the respective residences that they were booked for, it would have meant that they would have had to follow a scheduling of tests at different laboratories where there were lots of queues. And at that stage, NDOH had its specific approach on testing because they were doing mass testing. There was no way that they were going to change their model to just go and assist those members specifically in the Western Cape for the reasons that I've already mentioned. Once we assisted these members, Chair, if you recall at COVID, you need to get your doctor referring you and the result must be then sent to your doctor. These members were not at home. They were not next to their providers who would take care of them. We also had to make sure that we get doctors who will be able to assist us with the referral and receiving results and communicating results to members, to the extent that some of these members actually were positive. It meant that all the members who were exposed to these members at that specific time had to be isolated. The other challenge, Chair, during COVID again, a member who tested positive could not go back to his family because the parents or the partner had comorbidities. We had to devise means to get this member to an isolation quarantine site at that moment in time because there were no beds. Specifically, this was in KZN. We had to devise means to get this members to get this member to an isolation so that they don't go back to their family to go and expose their partner who had comorbidities. So the reason we gave examples of some of the issues and challenges that were experienced during this specific pandemic, and the experience that SAPS members actually had is that we did not say department was unable to take care of those members. We are just saying because of the unique circumstances and the unique needs of SAPS members at any given time, SAPS had to ensure and make sure that processes are followed before members can either be taken back home or put on a program to go elsewhere in the country. The speech therapy and auxiliary services, Polmed is a traditional medical scheme. We do not have a savings option. We allocate benefits according to different benefit categories. So Polmed does cater for speech therapy and occupational health, and it is covered under auxiliary services. Growth over the years, General Gwena has addressed that. And the benchmarking that was done in the SAPS submission, Chair, that information is clearly and extensively covered. SAPS did a benchmark exercise in the developed countries and not countries that are not developed, and where countries were developed and specific care was taken to the whole universe. There's their police are included, but in instances, even in the developed countries where the NHI was not that well established, there was a different dispensation for the police. In the not developed countries, what we are requesting is exactly what is happening there as well, Chair. Just to clear that we have not requested this specifically without reason. We can resubmit the initial submission that SAPS did. As to how we envisage Polmed coexisting in the NHI space and whether Polmed members are prepared to follow the care at defense, we are happy, Chair, to submit a motivation in relation to how we envisage taking care of these members in a specific platform, using specific tools and services at that specific time. The board has actually made decisions around some of the care that SAPS members should get at targeted places. Yes, Chair, vaccine rollout was tough because of the stringent rules that were in place. We needed to ensure that purchasing of vaccines were done according to the NTOH standards, storage, etc., transporting, all those, Chair, had to be taken into consideration. From our end, putting our members together and making sure that members get the vaccines was not a difficult exercise from SAPS perspective. It was easy for SAPS to put its members in specific groups, and we then provided, as the scheme, we then provided care or the vaccine to our members based on the protocols that the Department of Health expected us to follow. Other than those restrictions and strict conditions, when it comes to giving care to our members, because we are always in collaboration with the employer, which is SAPS, it becomes easier for us to take care of our members. Again, to reiterate, Chair, we have not submitted that NHI is going to give substandard care. we submitted that the current offer that the SAPS members have been receiving, particularly because even in the submission by SAPS is explaining that Polmed is part of its members' benefit. Some of the members that some of the employees that are still at SAPS have stated and are still stating that they are in SAPS because of Polmed or because of medical cover. If Polmed was to be unplugged, there is a possibility that SAPS might see influx or exodus of some members leaving the force. Clearly, because the salaries of Polmed, of SAPS members obviously were augmented so that they are given a comprehensive medical cover. That's part of the main reasons SAPS is also requesting this exclusion. We highlighted mental health as a challenge, but not as the only challenge. We also have not indicated that in the NHI space, mental health would not be addressed. It is because of the issues and challenges that we've already experienced at the moment that prompted us to lift specific to mental health, because it is experienced in the police. It is no secret that police are under constant pressure from all sorts of things. They become social workers, they become marriage counselors, they become teachers, they become parents, they become midwives, they become anything at any given point in time. And society, in most instances, is not very supportive to the police. The other concern that has been raised is that it's going to be unfair for Polmed or SAPS to request this exclusion because its dependents are also covered in Polmed. It is the very dependents, Chair, that have to deal with or grapple with the issues and challenges from the members of the SAPS when they go back home. We, like Dr. McKing put a disclaimer on his presentation, Chair. We are happy to, at the opportune time, to give specifics of what is happening at SAPS or at Polmed and its members. We see children as young as 9 years old with some of these mental conditions. We have not highlighted those because we focused on the active member of the police. But we are happy to share on condition of confidentiality with specific chair members, so that you actually see that although at the moment we believe that it will be unfair for even the dependents to be catered for in the proposed model, it is also equally unfair that these very same family members are the ones that have to put up with members when they come frustrated back from work, and that they are also experiencing almost similar issues and similar challenges, because an angry employee of SAPS, when they get home, they all of a sudden don't get excited, or they don't change, and the mood doesn't change for them to be happy and forget about what happened at work. Their dependents are also affected to the extent that Polmed also covers the dependents of the fallen heroes. We are not saying NHI is not going to cover those. We are just indicating to you, Chair, how extensive Polmed cover is. We are also happy to propose the amendment to section 3.2 as suggested by the member. We at the moment are unable to respond to that. Polmed only covers those members that are employed under SAPS Act. Those who are employed under a PSA are covered elsewhere. Polmed doesn't cover for those. Another question spoke to loss of synergies. In previous years, Polmed collected data and kept this information. SAPS, on the other hand, collected some of the data, kept the information, and the two did not understand who is dealing with what. SAPS itself thought the information that they have would assist them in scheduling of its members or assisting its members to deal with health challenges that they had. Polmed as well, on the other hand, had all this wealth of information, but they couldn't assist in putting together some of these programs that would assist SAPS. As I've indicated in my presentation, the programs that we've highlighted are the ones that we have implemented specifically this year. We have many programs, and the smoke cessation and weight loss program, we haven't excluded those, and we haven't suggested that they won't be there in the NHI, but because we are we put programs targeting specific issues and challenges in the SAPS. We now build these programs, and the synergies that we're speaking to is that we go back to SAPS to assist them in dealing with some of these issues, challenges that they have with some of their members that are struggling with weight that is not commensurate with what is expected of them to perform their duties day to day. The introduction of medical insurance has actually hit us very hard in that members would affiliate to these programs. Some members, it's not all of them, get themselves admitted, and the provider obviously will claim from Polmed. The member will obviously claim from the insurance entity. So that was part of the fraud component that Polmed had to deal with. And again, because of collaboration, because of data analytics that we had, we could pick those up at a very early stage, and we could intervene to the extent that there were members or dependents who basically registered on these products and on a monthly basis just ran into hospitals, because when a member calls us for a pre-auth and the request meets the criteria for us offering that pre-auth, we do give it. And our follow through in hospital, again, the hospital or whoever is dealing with this member in hospital will give us the required information. We have no reason not to approve and pay for that specific claim. Only when we really see that this member is consistently going into hospital would we either pen the pre-auth. In one of the instances, the member whose pre-auth was put on hold actually got out of the bed, got to Polmed administrator and say who declined or why are you not approving my pre-authorization, and the member said, what do you expect me to do? I get admitted because I'm feeding my children with this product. So it's those circumstances that we had to we're faced with, that we had to clean out and to ensure that we don't have such challenges. But those products were a big problem. They are still a big problem to us. We are happy that they've also made some changes on their end, that you no longer get 100,000 for 3 days. There are specifics and there's conditions attached to the payment of this medical insurance.
I have to just quickly interject.
Chair, I think that's about it. Thank you.
Thank you very much. Just one quick question.
You're on mute, Chair.
I am not. It doesn't look like it. So you can't hear me?
We can hear you.
Chair, just a quick one, just to respond to the last question that was asked in relation to the relationship that we have with the administrator as Polmed. Our non-healthcare cost is one of the lowest in the industry, at 3.7%, and 1.9 goes to the administrator. Polmed has got no relations or ties permanent chair with any administrator. We've just went on tender for administration services. So over years, when the contract comes to an end, we go out on tender to attract. So we have no relation with any administrator. And we are proud that whatever contribution we collect for our members go to the needs, health needs of that member, and not to the non-healthcare, as indicated in the previous presentation. Thank you, Chair.
Thank you very much. Just a very quick question, which I am to ask on behalf of another member, whether CMS has found, what has CMS found on the operations of Polmed, and whether there is any declaration that Polmed needs to make with regards to the findings of the CMS. If this is too quick for you, maybe one of you can maybe answer this very quickly in 2 minutes so that we can move to the next presentation.
Chair, we are not aware of any findings, except a few matters that were on the table that were dealt with CMS, and those matters, some of them were closed. Thank you, Chair.
Thank you very much. Let me again thank you for coming, your entire team, to come and do these presentations to the Portfolio Committee. We appreciate it very much. And just as we're about to then let you go, if you maybe any of you want to say a last few words, you're very welcome.
Thank you, Chairperson, Honorable Chair, as well as honorable members. From Polmed, we say thank you for the opportunity, because sometimes when you get platforms like this, it's where we articulate the processes, what is happening internally, and we dispel of the myths of what we hear in passages. We really appreciate this opportunity to come and present in front of the whole populace as well as the Portfolio Committee. Thank you.
Thank you very much. You are welcome to stay on. You're also welcome to leave this platform. We are going to move on with our next presentation, honorable members. We are now behind time because we have a 45-minute presentation. 5 minutes for discussion, which would then take us to 15:31, if I am correct. So 13:41, actually. Very welcome, Ms. Nompumza. I see you have switched on your camera, so I would assume you're leading this delegation from MedScheme. If I am correct, you can just nod so that I can do a proper, thank you very much, proper welcoming. I welcome you and your entire team, honorable members. We will now be receiving a presentation from MedScheme, and you can go right into it. Thank you very much.
Am I audible enough? Good afternoon.
Thank you very much, and we can see you very clearly too.
Thank you. Good afternoon, honorable members and all protocol observed. Firstly, I think we would like to really thank the committee for the opportunity afforded to us. We're actually very humbled by this prestige invitation to come and share our views on the Energy Bill. I think just one correction though, we as mentioned in the agenda, we are not a medical scheme. However, we are an administrator, which I'll provide a view on who we are just shortly. So we'll be sharing, today we'll be taking you through the following. So we'll just quickly provide an overview. I'm wary of time. Provide an overview of who we are, our commitment to universal health coverage, share Energy Bill views, which we had shared, in fact, with submitted as part of the submission process, which was in 2019, And then I think just lastly summarize what we believe are the success factor for NHI implementation, which we strongly support and strongly believe in the spirit of Ubuntu. So today I'm accompanied by two of my colleagues who are also online. So perhaps just as a way of introduction, I'm just going to ask them to put their cameras on. So I'll start with myself. So my name is Fezeka Nombumza, and I'm the Executive Director looking after the clinical and advisory divisions of MedScheme. On the call, I also have Dr. Mike Marshall, who is an Executive Manager in our Research and Product Development Department. And lastly, I've got Dr. Samukeli Sodube, who heads up our Group Health Policy Unit. Okay, next slide. Okay. So just on our purpose, I think it's quite important that from where we are, our purpose is fairly intertwined and self-explanatory. We create value through purpose. So and our real purpose is to enhance the quality of life. Our vision is to transform the healthcare services, and which we believe the ethos of NHI is just that. And then lastly, our mission is to innovate a new integrated model of sustainable healthcare that measurably improve access for all, and thereby providing quality healthcare. I think there's just a slide that we missed. Apologies for that. Before that. Oh, yeah. Yes. Thanks, Samu. Okay. So, honorable members, MedScheme is the largest health risk management service provider and the second largest medical aid administrator. We reach over 3.9 million people in South Africa. We've got a presence in Botswana, Namibia, and Mauritius as well. We are part of an Afrocentric group, which is a diversified Black-owned JSE-listed investment holding company, providing services and products to the healthcare sector. What is quite important is that we employ over 5,000 people. I've also listed some of the schemes or the schemes that we manage, which some are open and some are closed schemes. I thought it would be prudent, and I know I haven't shared those statistics, but I think it is prudent that I share with you some of the stats that demonstrate the scalability of our operations. On average, we handle about 20,000 calls, 18,000 emails daily, with over 270 million in claims that we pay daily. And the total claims expenditure that we manage on behalf of our schemes is around 80 billion. And I think what is of importance as well is that the majority of these claims goes through what we call straight-through processing, and they are paid within seconds from the time of submission. From a medicine management, we have an internal capacity through our pharma cluster, where we process over 1 million scripts a month, which is between private and public sector. Again, a demonstration of how close collaboration between private and sector can work. I think to this end, we have the human capital, we've got the healthcare funding IT systems, and all the managed care services in the NHI context from an experience and from an expertise point of view. Okay, I've spoken about that. I think what I'm going to share with yourself is really just another way of demonstrating how, when the public-private partnership model, how it's worked. And here, we've collaborated and we've seen an unprecedented, I think we all know what COVID has done. I mean, it's an unprecedented time that our country has ever seen. But the close collaboration for the greater good of society in the fight against COVID. And what I'm going to share is some of the tangible interventions that we deployed as a collective. At the face value,
there was no differentiation of whether you are a private member or whether you're a public member. Everyone got the same care. We managed to deliver and process in terms of payment for those vaccines. In terms of supporting members, we provided access, in terms of credible information through multiple interventions for ongoing support. We had a COVID-19 resource hub. We had a direct advice to infected members with a dedicated COVID-19 call center, and these were all Med-Scheme initiatives. From a protection of members, with a targeted engagement plan to mitigate infection risk and nudge members to be vaccinated. And here, what was important is that we had 6 Afrocentric vaccination sites, but I think what I have not mentioned in this slide specifically is around our ability to mobilize over 3,000 nurses to go and assist with vaccine or vaccinations at the sites. In terms of supporting providers, them being a critical member in the entire value chain, we've provided PPE and lower tariff negotiations, or rather negotiated lower tariffs with them. We set up telemedicine and virtual consultations, also at a laboratory negotiations in terms of COVID-19 test prices. We were at the forefront of that. And then lastly, from a supporting society, like I mentioned before, we collaborated for the good, for greater good of society. We created additional vaccination sites for members and non-members. And then lastly, that whole regulatory ensuring that there's a collaboration with CMS in terms of PMB legislation. I'm now going to hand over to my colleague, Dr. Samu, to take us through the remainder of the presentation. Thank you.
Thank you very much, Fezega, for that introduction. Okay, so thank you, Chair, for the opportunity for us to present as Med-Scheme, and good afternoon to the honorable members and all protocol observed. I want to take you through, because our submission, which we did in 2019, does make reference to the health market inquiry. And we do highlight, particularly in this slide, that it is important for us to move forward from the fee-for-service model that we're currently seeing, that actually fragments healthcare and is making it very expensive. The highlights that are important for us is the move towards the alternative reinvestment models, where in the right upper quadrant there you would see that would make more savings if we move to population-based mechanisms, and obviously if we adopt global accountable care organization mechanisms, we become a more market innovative society. But for us as a country, ladies and gentlemen, to move towards that quadrant, we need to look at other legislative barriers. In particular, we do make reference to the Health Professions Council's interpretation of the ethical rules, where this needs to be looked at for us to be able to move forward. We also make a reference to another health market inquiry finding, where we do upload the informed nature, where we say we want to roll out the NHI in a transitional fashion, and we do acknowledge that for us to be able to achieve that well, it should be well considered sequencing, and there is one important part of the NHI that we also upload, the move towards making sure the quality outcomes have got a measurement reporting system. When we adopt this, ladies and gentlemen, we know that those measures ought to be acceptable, they ought to be feasible, reliable, sensitive to change, and their predictive value should be on point. And we do again emphasize that when we're rolling this out, when it's phased, we will make considerations around quality of care, and we will make considerations about the sequencing of this transitionary period. As Med-Scheme, our commitment to universal health coverage is unwavering. recognizing that we are in an environment where South Africa is a fragmented healthcare system, we ought to work together to make sure that this, not only is it accessible, it should be affordable, and it should be of better quality than we are seeing now. And its value should be worth buying. But for us to move into that space in a sustainable manner, it needs to be phased, as I've alluded to before. It also needs to be inclusive. And this inclusivity is about the role of the private sector in making sure that NHI works. We are willing, Chair, to work with government to make meaningful progress in this particular journey. It's not just a UHC journey, it's a journey that is important for South Africa as we rally towards the Sustainable Development Goals. Our submission does make mention of several comments that I want to allude to in terms of the submission that we made in 2019. In particular, I'm going to start with the issue that has been raised around the monopsony of the NHI fund. So we do believe, actually, the literary translation of the word single means that no one else can perform that particular function. And our recommendations in our submission are clear about the need to amend that definition to exclude the term single, because we believe that there is an environment where medical schemes and other private providers could play a big and meaningful role in purchasing and paying for healthcare services. The second issue that we want to make mention to in this unison pursuit of the universal health coverage is the role of the provinces in the NHI. We know that, and we acknowledge that the Constitution of South Africa makes provision for federal fiscal system and makes provision for its sanctity. And therefore, the role of provinces within the NHI, whether it's their purchasing power, whether the role that they should play in provision of services, it needs to be clear. And we do submit, therefore, that the institutional, organizational, and operational reforms provided for in the bill need not go against spirit of the Constitution. In fact, this should be resolved by including a separate section in the bill that clearly outlines the functions of the provincial departments of health. Members of Parliament and honorable members here, we do submit the important role that Medscheme and other players in the private sector would play in ensuring the success of the national health insurance. In that, we do submit that we need to remove the restrictive, any restrictive legislation or submission that restricts the role of schemes in purchasing and in paying for healthcare. In particular, we make mention of this in Section 33 and in Section 8. Private voluntary healthcare insurance has been and will be and could be a major catalyst for us to achieve our universal health coverage goals. We therefore recommend that there be an inclusive path for private sector, not just as a provider of care, but also as a funder and as an administrator, as Medscheme is actually playing right now in private healthcare. When we look at other countries around the world, and I make mention here of the Netherlands as an example, whereby the state regulates and exercises oversight with involvement of private insurers, we believe that has worked well. We know that there is no system that is completely perfect, but we believe that this could be a role that the state could play. Inadvertently, we know that access could be improved when we all advance the standardized basic package that could be an entry for us to achieve universal health coverage. Another observation that we make and we put in our submission is the role of the other state entities which currently purchase healthcare services. We make mention here of the role of the compensation fund and the road accident fund in particular, who are funding sources of healthcare currently in South Africa. We believe that the bill should include a chapter or section that addresses this issue, And we also believe that there is need to mention their specific, to reference them with regards to their role during the transitionary phase and also post the creation of the NHI fund. This delineation of functions is important for us to move forward in a non-conflicting way in the NHI. Ladies and gentlemen, there are issues around when we are advancing a free market economy, competition laws. We do acknowledge that the NHI bill does make mention of the supremacy of the Constitution of South Africa and does make mention in the Public Finance Management Act in Schedule 3A that there is provision for the NHI bill. However, as we proceed forward, we believe that competition ought to be allowed. Managed competition has been known to improve access, has been known to improve innovation, and has been known to improve quality. And we believe there should be provision and ample provision therefore for competition as we execute on this bill. Further, as we look at the complaints and appeals process, we know that the Consumer Protection Act would make provision for such, and there should be clarity on the interplay between the provisions of the bill and those of the Consumer Protection Act. Through you, Chair, we submit that the consideration of not making the fund exempt from any competition law. There is provision, the issues of governance in a country. Good governance has been known over years to not only improve the quality of life, but we know that the improvement of that quality of life and the aspiration and optimism that we have in this country in terms of human development can only be upheld if we've got good governance. And as such, we cannot falter in this particular issue. There are two issues that we make mention in our submission. The first one is the selection of the board. The ad hoc advisory committee in the selection of the board, we submit that there be clear criterion on how this would be selected. And we would submit again that there should be inclusivity in the medical schemes, especially in the stakeholder advisory committee. Such would bring not only robustness in the governance issues, but would bring in a plethora of expertise that exists right now in the private sector. Governance issues often filter through in the operations framework. In particular here, we do make mention of how the primary healthcare model would work. We submit and we do ask that we make considerations to make clear definitions of the multidisciplinary teams, especially in the primary healthcare model, and further that the registration of patients, there be more clarity in the registration of patients, wherein there is mentioned that both an identity card and an original birth certificate should be submitted, and we say that it should be either or, and there is provision again for how the biometric system ought to work, and we submit that there should be clarity in terms of how contractors who are working in these facilities are going to be accredited, paid for, managed for, and even the maintenance of this biometric system. Ladies and gentlemen, one of the last submissions that we actually make here is given that the primary healthcare model is key in the provision of care and in fact in the gatekeeping of care, we do make in our submission a recommendation that seeks to clarify the role of the district health management offices and the contracting unit of primary healthcare versus the NHI fund, where we think this needs to be clearer in terms of the flow of funds. For example, we believe that the coexistence of both these would blot the administrative burden of the NHI fund, and there is need for more governance and accountability frameworks that would govern these two institutions should they actually coexist. Further, as I alluded to before, there is more clarity that is needed around some of the investigating unit, especially when you look at the risk, fraud, and prevention units. The last one is other institutions that are already provided for within the Health Act and other statutes of the healthcare provision in South Africa. For example, the Office of the Health Products Procurement, SAPRA, and the Office of the Healthcare Standards. These need to be clearer in terms of how they are structured in relation to the NHI. Ladies and gentlemen, thanking you for the opportunity for Med Scheme to present, I would like to conclude that a few issues that are salient in the bill ought to be elevated more so that we can work together in the spirit of Ubuntu to make South Africa's healthcare system work. In particular, the contracting model. We believe that there is lots of expertise and experience in the private sector that the government and the NHI bill could leverage off to make NHI work. In fact, our experiences that Fezela mentioned earlier around COVID-19, they show and they demonstrate that there is ability to scale in the private sector. And we believe that through our operations systems and processes, we will be able to scale this up together. Indeed, even our track record around innovation and systems reliability could be leveraged so that we could get this going on sustainably as we roll out towards the universal health coverage. We know and we are not naive of the technology and the IT infrastructure that is needed for us to roll out NHI. And we know that private sector entities do possess some of these technologies. And given that this is the magic link between all stakeholders who are presenting in these hearings today and they did before, they need to be linked together with technology. There is need again for a smoother experience, quality experience for patients, for members, and for all stakeholders, that there be an integrator of these products, and indeed combination of these products that I've mentioned before, whether it's administration, whether it's wellness and health risk management. We have done this before as private sector, and we believe that if we work together, we can achieve this in a robust fashion. Thank you, ladies and gentlemen, and I'm handing over to you, Chair.
Thank you very much. Thank you very much for the presentation. Let me thank you on behalf of the committee. We really appreciate you doing a shorter presentation. Allows us to do some catch-up time. Not that you have not done justice to your presentation. The honorable members, I have noted only one hand so far of those who want to raise questions with Med Scheme administrators. I must add, not a medical scheme. You can indicate here, please. So firstly, it's Honorable Sukacha, followed by Honorable Howard. You can also shout on this platform, please. Siwela is number 3. Honorable Munyai, number 4. Any other members? Any other members who want to raise questions? Honorable Gela is number 5. Mahlengwa, number 6. Anyone else? In that order, you may start raising your questions, honorable members. Thank you.
Thank you very much, Honorable Chairperson. Let me welcome the presentation. I've just got one question, Chair, from Med Scheme. Is Med Scheme's position that the NHI must be implemented in a duplicated environment? How will that address the core access and inequality challenges plaguing the current public-private split in the health system. Thank you very much, Chairperson.
Thank you very much, Chair. And I only have one question. In slide 13, there's reference to private voluntary health insurance acting as a catalyst for the move towards UHC in South Africa. How does MedScheme motivate this? Given that we have had medical schemes for many years in South Africa, and the challenges in terms of access, quality, and sustainability of the health system have remained unresolved. I thank you.
Chairperson, thank you. I also have one question. Does MedScheme support the notion of healthcare as a public good that is not dictated by the whims of market fundamentalism as articulated in the 2017 NHI white paper? Can MedScheme elaborate further on why they insist that the NHI fund must not be exempt from competition laws? Thank you, Chair.
Honorable Chair, according to the MedScheme, a single payer system under NHI is not supported. Yet, among other things, it has potential to benefit the healthcare system through the economics of scale, which can be derived from the pooling of various forms of resources and negotiating power that comes with it. My question is, Honorable Chair, we already have the multiple payer in our system, particularly in private sector, and the consumer are still deriving the desirable benefits from it. Why should we continue to advocate for it under the NHI? Most importantly, what is causing MedScheme to support such a system and propose that we extend to NHI? I want also to ask the following question. Do they support national health insurance as a vehicle that will really achieve universal health coverage here in South Africa? Because each and every country have its own mechanism to achieve the universal healthcare system. But I must also ask, I think Afrocentric and MedScheme, they are one and the same. The owners are the same. They just change one of the directors to go and become the CEO on the Afrocentric and the other. Can you please clarify that relationship? I'm raising this because in Parliament, we use Polmed. One of the most expensive, people are paying almost 16,000, 12,000, just 16,000. To a degree, some people can pay even 20,000, depending how you address your benefits. And it uses the old apartheid scheme as a process, not to allow freedom of choice as they are contesting the issue of a single, but of themselves in Parliament, that the single medical aid provider. Why not allowing their choice as aligned within the Constitution? But remember, in the context of the NHI, medical aid or scheme have the role to play. They can't want to be replacing the public policy or wanting to implement NHI. No, because the principle that they have is different. They don't have an element of solidarity and so on, So those are some of the issues. There's no way, as members of Parliament, will allow the private medical aid schemes, to implement NHI. No, it will be publicly administered in case there was such an interest. So, but if really they want to have the state, they must confirm if they want the status quo to remain, that of racialized two-tier systems, which 8% to GDP, which accounts for over 400 billion. It's in private medical aid schemes, which serve only the few populations. I don't want to say the elite, I'm saying few, while the rest of the populations are served by private sectors. In the context of current COVID-19 and all the infrastructure, all the hospitals were overwhelmed. I'm saying all because private and public, right? So these dynamics is a clear indication that we need NHI than ever before, if they can confirm. Thanks.
Honorable Gela.
Thank you very much, Chairperson. Most of the questions are covered by Honorable Munyai that I wanted to raise, but I've got one question that I want to ask from the presenter, but also welcoming their presentation before us as portfolio members. Out of the interest, how does MedScheme manage its governance issues, in particular the potential conflicts of interest between Afrocentric and MedScheme? In light of the NHI bill and its provisions, would MedScheme recommend similar relations as those inherent in what exists between Afrocentric and MedScheme? Thank you very much, Chair.
Honorable Slengwa. Are you there, Honorable Slengwa?
Yes. Thank you, Chairperson. First of all, let me welcome the presentation from the MedScheme. I have only one question or one seeking clarity question. What is your view on a possible funding models that could be considered, considering the lack of detail of that in the bill? Thank you.
Thank you, honorable members, for raising those questions with MedScheme and their representatives. I have a number of short questions for you. The first one has to do with your alternative reimbursement model, where you see it as an intervention that would be beneficial to the health system. Now, given that in your nature, alternative reimbursement models, whilst they vary in nature, they all lack the important elements of transparency and have potential to introduce inequitable distribution of resources into the health system, as well as fragmented pricing regimes for the same service. So what makes you think, if I make the statement that alternative reimbursement models should be considered under the NHI? And then also with regards to the move towards this alternative reimbursement model, have you engaged with the HPCSA regarding the identified ethical rules, and how can they be changed to address cost pressures within the current medical schemes environment? If you had done such, what was the outcome of those engagements? And then you have raised arguments with regards to the roles of the DHMOs and the CUPs. And it seems that you arguing that the roles should be consolidated to support better and efficient use of resources for the NHI fund in order for it to function better. Why does the same solution not seem to be appropriate for consolidating resources in the public and the private health sector to support the phased implementation of the NHI? Would this not lead to better use of available health resources to effectively meet the health needs of all South Africans? And then you've made a comment that the South African Constitution is based on a fiscal federal system provision. Are you aware of a provision in the Constitution that empowers the national sphere to intervene if issues related to equity and justice are not implemented by the provincial or municipal sphere? And in using Netherlands as an example that South Africa must emulate, have you considered the injustices of the past and the income inequalities that exist in South Africa? Thank you very much, honorable members, for those questions. Are there any other questions which any honorable members would want to raise? And if not, I will allow the presenters to respond to the questions which were raised. Thank you very much.
Thanks, Honourable Chair and honourable members for the questions. Between myself and my two colleagues, we will be responding to the questions in no particular order. The issue around the Afrocentric med-scheme relationship, and there were two questions relating to that, so as you know, Afrocentric is the holdings company, an investment company. I'll speak to the issue around governance, but let me just explain in terms of the relationship between Afrocentric Health and med-scheme and the issue around vested interests. So from an Afrocentric, and I'll speak to it in the form of the value Afrocentric Health brings in terms of the value chain integration to lower the cost of care. And I mean, if you look at our structures and the companies that form part of Afrocentric, you will see that we have, like I mentioned earlier, about internal capability in our pharma cluster. But these are all geared up of bringing the lower cost of care, and we pass those benefits directly to our schemes and its members through lower premiums or contribution. Some example is that our value chain integrations, like I said, allows us to push down premiums as much as 15% in some schemes. And if we didn't have these pockets of entities within our group, we were not able to achieve those. From a governance point of view, it is managed through robust service level agreements, contractual agreements, and ensuring that clients' interests are always upheld. So that is the response around the whole issue of the relationship between Afrocentric and med-scheme, and particularly around how we manage governance between the two entities. Okay, I'm just going to hand over to Samu to respond to some of the questions that we've taken. Honorable Chair, there was just one question we couldn't get. I think there was an issue with network or rather transmission. I think it is question 6, if my memory, yeah. Yeah, I think it's about question 6. So we couldn't hear what the comment was, or rather what the question was, because there was an issue in connection.
Now who raised that question? Is that a question raised by Honorable Siwela?
No, I think it was Mamuklem.
Fine, we can get her to repeat her question very quickly. Naklengwa?
Thank you. Let me repeat my question. What is your view on possible funding models that could be considered, considering the lack of detail of the aspect in the bill? Thank you.
Okay, thank you. Over to you, Sama.
Thank you. Thank you, President. And thank you, honorable members, for those questions. Quite engaging, and I think we have been very clear as Met Scheme that our quest is getting equal access. In fact, it's actually improved access to quality healthcare that is affordable for all South Africans. So there was a question around the duplicated environment that we sort of envisage this to be operating under, and we made mention of the transitional phase, which should be well considered and with proper sequencing, because what that allows you, at least in the initial stages, is to learn and course correct the implementation of the NHI without breaking the pillars of what may be working, and you want to make sure that the implementation is smooth going forward. So there is place for multiple flowers to bloom, especially in the initial phases as we learn how this ought to be executed. But even in the future, and this to the honorable member Xolisi, I think he mentioned the issue of the duplicated environment. I think it also relates to the competition issue that was raised again. We believe as Met Scheme that competition is good. And in this particular case, we speak about managed competition. Competition is good for innovation. Competition would be good for increased access, and competition would be good also for quality, because we believe that through competition also you are able, as it was alluded to, when you're looking at the single payer system, you are able to also bring prices down. It is actually a market economy. There was a question that related to the voluntary health insurance as a catalyst for achieving universal health coverage. If you're looking at the number of South Africans who are covered currently, and who have got who are under medical schemes, that on its own is part of universal health coverage, and ensuring that you take that burden away from the state, because people are paying for private health insurance, it increases coverage in terms of universal health coverage. And honorable member, that's what we meant by private voluntary healthcare insurance advancing universal health coverage. There was a question around competition laws, and I must just allude again that we are not saying we are not saying that we are exempting from competition, NHI from competition laws. What we are saying is that it's good to allow that managed competition to be at play because of the reasons that I've mentioned before. I will take a few other questions that were mentioned here. Fezega has alluded to the issue of governance that I mentioned here. And again, to Honorable Munyai, the issue of where Met Scheme stands around NHI, I think our unequivocal and unwavering support has been made clear. And this is in the principles of solidarity, and that actually is you say there is no element of solidarity, but this actually follows the principles of solidarity and Ubuntu, where we are saying, let us work together to make this a reality. I think I will hand over to Mike to answer some of the questions, particularly around funding models and ARMs. Thank you very much.
Thank you, Samu, and thank you, Bill. Thank you, Honourable Chair, for the opportunity to respond. Perhaps if I can just start off with the question that was raised, and it was within the context of Polmed, but I think I can respond to it more broadly around expensive benefits, not allowing a freedom of choice. Honourable Chair, a medical scheme, effectively, members pay contributions on the one end, and then there are claims that come out of the other end, and clearly they would need some sort of surplus to remain sustainable. And the contributions that one pays is generally a reflection of the profile of that particular scheme. In other words, how old or sick they are. Remember, we have a solidarity system in the medical schemes industry where there's open enrollment, PMBs, and community rating. So how sick that particular population is, and how much they claim. That's effectively how how a scheme is priced. And then obviously in between, one would need health risk management to try and manage those costs down. Now, we are in a healthcare environment in the private sector that I think was elucidated quite well by a very detailed health market inquiry report, which effectively, we're in a sort of transactional type of system where I guess quantity is rewarded instead of quality, and around that is a regulatory framework and systems that support that kind of transactional system. So the health market inquiry made a number of recommendations, many of which haven't been implemented, and it's pleasing to see some of them come through in the bill that could correct this challenge that we see. So I think what we're saying is that we have incredible skills and resources in the private sector. I mean, good examples of that would be, for example, technology, systems, data analytics. I mean, the complexity of that and predictive modeling, contracting, I can go on and on and on, that I think can add to a NHI system. And these are all complex things. Anyone that's tried to contract providers, for example, will know that it's not an easy thing to do at all. So I think that's why the benefits are expensive. It's just to summarize, a combination of what the scheme profile looks like, the claims look like, and then what the infrastructure is, the ecosystem is that the private healthcare sector is operating in, and there's a health market inquiry which has given a whole lot of recommendations on how we can correct that, and I'm sure that will make a huge difference and will bring this sort of NHI and private sector closer to each other. And if I can then go on from that and perhaps reflect on the question that was asked by the Honourable Chair around ARMs and whether they would be beneficial to a healthcare system or to NHI. I think in our view, one of the big evils in some way that is driving healthcare costs is this fee-for-service system or transactional system where you are rewarded for volume rather than outcomes and quality. And ARMs are an attempt to address that. Remember, fee-for-service also continues to drive fragmentation because there's not a collective responsibility for an outcome driven through an alternative reimbursement model. So we think that ARMs have an important role going forward. But the Chair, you're correct around transparency. I think one of the key components of putting together these ARMs is transparency in terms of what's in there and what's out of there, and the flow of funds. Otherwise, they don't work. And I think that's shown world over where ARMs have been implemented. And Chair, you mentioned again whether we'd engage the HPCSA. We have had in the past engagements in the HPSA. We've recently tried to implement global fees actually in a specific environment, and we've done it in the past in the orthopedic environment. And I mean, there are challenges around that, in that the sort of ethical rules around how doctors can practice are not always in alignment with the principles of ARMs. And I think some work needs to be done on that, because when one does try and implement these things, it's very easy for someone who perhaps is not interested in ARM to go on a regulatory fishing trip, so to say, and try and find reasons to maybe stay in the fee-for-service environment. Let me see what else. I think, yeah, the single system, I think Samu's addressed that. That's my input. I don't know if there's any questions that we've missed.
Chair, through you, I think Mam Kling's question, probably Mike has responded to it to some detail around the possible funding models. So there's plenty of funding models that are available, and ARM, I mean, is one of it. So we want to believe where we are. We've responded to the questions that have been provided. And again, once again, I really would like to thank the committee for this prestige opportunity that's been afforded to us to form part of a very critical milestone for our country, that being NHI. So we're really looking forward to further engagements through public participation, private participation. We are availing ourselves to share the experience, to share the journey and the learnings that we've learned. And again, we want to reiterate our commitment to universal healthcare coverage and the belief and of NHI. Thank you very much.
Thank you very much. Let me also then thank yourselves for coming to make this presentation to the Portfolio Committee. We are really on a journey of getting to know what is happening in terms of the health space in South Africa, so we do appreciate that. And just before we let you go, can you maybe, if you want to, say a few words? You're very welcome to.
I think from our side is really a like I said. I mean, I would be not wanting to rehash what we've presented, but I think just to put it in everyone's top of mind, as we said, as MedScheme, as Afrocentric, we definitely believe in the ethos of NHI, and we're supportive of it. That's all we want to say. So we wouldn't really dive much. I think we've said what we needed to say. And thank you very much for the opportunity. And thanks to the members, and thanks to you, Chair, as well.
Thank you very much. You're welcome to leave the platform. We appreciate you coming today, and we will be moving on with some other work. Honorable members, we are about to upload or flight the minutes of our meeting of the 8th of December. We would like to complete these minutes and have it adopted now before we move on, and then after that, I will give you an indication of the program for tomorrow. Ms. Majalamba, can you flight us those minutes? So, honorable members, first page to look whether you've been indicated as being present on that day. And second page, also still attendees to our meeting. Third page. Third page is just our stakeholders whom we had for presentations. Number 3, page 3, anything you'd want to add? or think we'd made a mistake with the capturing of those minutes. Page 4. And I would hope that the honorable members would have read through the minutes, page 5, page 6, and then lastly, page 7. Can I ask for adoption, a mover for adoption of these minutes, please?
I do, Chair. But some of the content I will not remember because this is last year's business, and we are doing it in February. So we should not prolong next time for 3 months, Thanks.
Chairperson, I'm seconding the approval of the minutes.
Thank you very much. So those minutes are duly adopted, honorable members. It brings me only to the very last section, which is on tomorrow's program. I have made remarks about the challenges which the committee secretary is having at times with either getting hold of those who had indicated they wanted to make presentations at the email addresses or their telephone numbers. And then also once we've had an indication, there are also withdrawals, or rather I would say a request for postponements. In this case now for tomorrow, we've had a request for postponement from the National Planning Commission. And we had thought it well to have allowed that postponement. So tomorrow's program will start at 11:25 in the morning. And we will have presentations from Mediclinic, Hospital Association of South Africa. We will have a long lunch period because we have not been able to get another group in the place of the National Planning Commission. And then at 15:45, and if it's possible earlier, but at this point in time, it's at 15:45, the Western Cape Government Department of Health, and followed by SALGA and by the Life Healthcare Group. If it stays as it is, we will finish at 19:35 tomorrow, just for you to note and be aware of that. If possible, we will try to make that a little bit earlier. So, honorable members, thank you very much for your participation and for attending. And to all of our staff also for the sterling work which they do in order to assist us to take this forward. This meeting is then adjourned. Thank you.
Thank you, Chair.
Recording stopped.
Thank you, Chairperson.
Thank you, Chair.
Thank you very much.
Goodbye, Chair. Bye-bye.
Bye.
Bye.
Thank you, Chairperson. Bye-bye.
Thank you very much.